right. Welcome back to the Hurwitz Lab. Hey, Alan.
Hey, Craig. How you doing?
I'm doing good.
Great.
Today we're talking about salt transport, and we hope you've seen our discussions on water balance and also countercurrent multiplication, which provide a great foundation to now discuss salt transport along the nephron. And we again are going to find ourselves in Alan's house, which is everything channel, pump, exchanger, and the approach we're taking is to discuss each region of the nephron with respect to the epithelial transport features of that segment, followed by pharmacogenetics and disorders. So you know as well as I do, we're in for an exciting and beautiful tour of the nephron. Grab some salty chips. Let's get to it. Alan, Happy New Year.
Happy New Year, Craig.
I can't think
this
of
is our first podcast of the new year.
That is for sure. And I can't think of a better way to kick it off than with this one.
Well, yeah, and you know, I spent New Year's alone with my salt and water, and at midnight,
And the cat.
At midnight, all the transporters popped up, and I had a fireworks to transport.
Oh, I love it.
So this is two kidney guys in the flow state.
Hey, man, I like the name that you came up with this.
Yeah,
I think it's really good.
okay.
And actually, you can see here from the slide that we've done a number of other deep dives on these topics.
This is number 7.
This is number 7. Awesome.
Okay, you ready?
I am ready.
All right. Well, I was very happy, as we were preparing for this, you were telling me that, by going back and looking at some of this stuff, you almost feel like you're doing another fellowship.
Yeah, I got to thank you. I mean, it's going back and doing these reviews, getting ready for these, getting prepared for a discussion with you on these topics is a big deal. So, I mean, that is a lot of pressure for any nephrologist, but it is awesome. And like I'm saying, I mean, I'm feeling so prepared. Almost though, sometimes you can know too much about things, and we've talked about this.
And that gets you into trouble on exams.
It can get you in trouble, but still, that's what life is about. And if their questions are that crappy that if you know too much, you're going to get it wrong, then their question's a problem.
Right. And today we're going to do something a little different, because today, you have never heard me say this before, we're going to take a deep dive.
Hey, I love it. I've never heard that before.
No, you never heard that. So again, as you mentioned, we're going to talk about the physiology, pharmacology, and molecular genetics along the nephron, because they overlay perfectly.
Yeah. And
I was very lucky to be at Yale during the time where many of these things were worked out on the molecular level.
Mm-hmm. What years were you at Yale again?
So I did my clinical fellowship in 1988
we got to shut our phones off, by the way.
1988 to 1989, and then went into the lab in 89, and stayed there till I left for Vermont in 96. So my fellowship, I asked Peter Aronson, because he said he's still a fellow every year, and and I said, by the way, Peter, when is the fellowship over? And he goes, oh, that's easy. It's when you get an NIH grant.
Right.
And so I was a fellow from 88 to 92, because in 92 I got the physician scientist training award. And then from 92 to 96, I was what they called an associate research scientist doing the lab. And during that time, as I'll mention, when you see the fellows behind me, so fellows ahead of me worked out some very interesting things, like autosomal dominant polycystic kidney disease were worked out by Steve Somlow and Greg Germino a lot when they were in Steve Reeder's lab at Yale, and then went and had their own labs. And obviously much of what we know comes from their work. They were real pioneers. And then behind me was some great transport stuff with the molecular genetics, because Rick Lifton came to Yale. And I remember having going out for lovely cappuccinos with Rick, talking about molecular genetics and transport. And then 3 fellows who were 3 Yale residents who then came into the fellowship program, all worked in Rick's lab, and you're going to see the work they did, which all basically came out in Nature Genetics.
Yeah, right.
And worked out all this stuff. So I was very lucky to be with those people. And also when Cecilia Canessa, who cloned ENaC, came to Yale, after I first met her, at an ASN right after she had her Nature paper showing the clone, and Peter Aronson met her then and recruited her to Yale. So it's a very Yale story.
And I felt like Yale came to me when I had you as my mentor. When I was at UVM, I was like, "Oh my God, I knew it."
Well, that was hopefully what would happen. Now, So let's first talk about, what is a diuretic? So everybody knows, they heard the word diuretic since their baby clothes in med school or even college. And, it turns out that a diuretic is any substance that increases the flow of urine. We love that because it's flow. And the root is, of course, Greek. And it means through urine. Through urine is what diuretics means. So it means through, like a diameter. And urine means urine. So diarrhea, which was a term coined by Hippocrates, is a flowing through. And again, we have our dia, which is through, and then rheostat is a kind of a flow thing. So rhean means flow. So then we have diabetes. And diabetes, there's two main types, as you know, diabetes mellitus and diabetes insipidus, and it's both the passing of certain kind of urine. Mellitus means sweet urine, and insipidus means tasteless urine. And so I thought I would ask you, what substance, given that a diuretic is anything that increases the flow of urine, what substance would be the best diuretic? What produces the highest urine flow rate?
Well, we've had this discussion in the past, and it's water.
Yeah, water. Nothing makes your urine flow like water.
Right.
And the only thing that may be better than water is beer. Because not only do you have the 95% water in the beer, but the 5% alcohol could inhibit vasopressin, which gives you even more. So, I have kidney stones, which is very embarrassing. And in addition to being on chlorthalidone for my kidney stones, we'll talk about that today as a way of lowering urine calcium.
Right.
I recommended to myself and to other people that have kidney stones, it's the right time. A beer is not so bad. It produces a nice urine flow. Okay, so we come back to Homer Smith. We start with Homer, who lived from 1895 to 1962. And we've seen this slide before, and it basically shows that when Homer gave himself a saline load and a water load, the difference in what happened to his urine output. Right. And so you can see clearly the water is what made the urine flow, because it's protecting body tonicity.
Right.
And, the body tonicity is the intracellular volume regulator, and cells like to be their volume, and any perturbation is going to engage the system very quickly. So a water load will be excreted much more rapidly than a saline load. Okay. So diuretics is a classical word, but of course, now that we know that the kidney certainly knows the difference between salt and water, when I was a fellow and wrote my first as a second-year fellow, I had to give talks to the residents or whatnot, and I wrote my first salt and water handout. And that was before aquaporins were cloned. But I said, we have to distinguish between an aquaretic and aquaresis, which is meaning that your flow of urine is water. And this would have to do with vasopressin and ADH. And these are used clinically. That was before we had aquaretics, but then the aquaretic, the Vaptins came out. And we use them to treat water overload states sometimes, like SIADH. Now, natriuretics are the ones that are the clinically useful diuretics when you're treating people for high blood pressure and for volume overload, congestive heart failure kind of things. And, these are the big things. And all of them do one thing in common. The Nephron has developed a whole bunch of different ways to transport and reabsorb sodium. And basically, a natriuretic is anything that interferes with the sodium uptake step. So if you've invented something and it interferes with the sodium uptake step along the nephron, you've invented a natriuretic. And that's going to have a clinical use in treating volume overload. So I like this slide. This actually comes from the little monograph book by the two Bruces, Bruce Keppen, who was my physiology teacher at the University of Illinois after he'd been at Yale, and Bruce Stanton, who was in Gerhard Giebich's lab originally. And the two Bruces got together and wrote a nice book. And what this shows on top is that basically aldosterone, the overall steady state effect of aldosterone is to give you a net gain of isotonic saline. So you see that when aldosterone is put on, these two things show what happens to sodium excretion. And you see that as soon as aldosterone goes on, there's a difference, and what happens is you gain weight because you're reabsorbing in the presence of a constant intake. Right. You're basically reabsorbing sodium.
Right. So your excretion drops.
Yeah, and so and then you come into a new steady state. So you don't even if aldosterone is on forever, you come into a new steady state, but the feedback system is such that your volume is now high enough for you to excrete your salt load again, and when sodium in equals sodium out sodium out equals sodium in again, you're in a new steady state. You don't just, and it also explains why when you take a diuretic, you don't turn into dust.
Exactly. And these are the talks I always have with patients. We do this over and over again when they say, I'm going to keep peeing so much.
Yeah,
and
no, you're not.
You're going to reach a steady
You're going to
state.
reach so here's the steady state at the higher weight, because you've had aldosterone. And again, when the aldosterone is turned off, you see the exact opposite happen, and you come back into the original steady state again. Now, a diuretic is basically the opposite of aldosterone. In the steady state, the diuretic causes a net loss of isotonic saline, and the same book shows the same thing. Here again, a diuretic is put on. You see the changes in the urinary excretion. And again, here's a loss of body weight. You come into a new steady state. And when you go off the diuretic, you come back. So as I just mentioned, I take chlorthalidone.
Right.
I'm not a piece of dust.
Right.
And I take it every day, every night actually. And so this is, you got to remember that the reason that diuretics are clinically useful is because of their effect on the natriuresis, the net gain or loss of isotonic saline, which we talked about in our first discussion. So keeping that in mind, here is our favorite diagram of the nephron. And you see in this beautiful New England Journal diagram of the nephron that it labels the different nephron segments and what diuretics, the clinically used diuretic, carbonic anhydrase inhibitors in the proximal tubule, loop diuretics, of course, in the loop, thiazides in the early DCT, and the so-called case-bearing diuretics in the collecting duct. And we're going to talk about this in great detail.
Following pretty much that path.
Exactly.
Following
Following that path. So let's get started with the proximal tubule. And here's, a little animated diagram that I made a while back. It shows a proximal tubule cell, and it shows there's the sodium proton exchanger on the urine side. This is Peter Aronson's favorite protein. And it shows the sodium bicarbonate co-transporter, again, cloned at Yale. Mike Romero was in Walter Boron's lab, and they were having some trouble cloning it from mammalian. Actually, they cloned it from our little salamanders, believe it or not. Became a good source of the tissue to clone the NBC. And of course, a very important protein. So let's see what happens. So what happens is that sodium and bicarbonate get freely filtered, and they come into the lumen of the tubule. And the sodium is picked up by NHE3, and NHE3 has to get a proton to secrete to be able to move. So what happens is carbonic acid here, through the action of carbonic anhydrase, splits into a proton and a bicarbonate. The proton goes down and meets this bicarbonate. That leads to the formation of carbonic acid in the lumen, again, through the action of brush border carbonic anhydrase, splits into CO2 and water. And what's neat is that CO2 can get back into the cell. And when it gets back into the cell, it can meet a water and also become a bicarbonate. So what happens is our paradigm of secrete a proton, reabsorb bicarbonate, this is the way the proximal tubule reabsorbs the majority of the filtered load of bicarb. And when this doesn't work, you're going to get a proximal RTA. So the motif of secrete a proton and reabsorb a bicarb is very important. And then other co-transporters are linked to sodium reabsorption, because the kidney is faced with the problem of all the sodium has been dumped into Bowman space, and you're going to die of shock if the proximal tubule says, no, that's not going to happen. And so the proximal tubule immediately does what it can, and look at the beautiful thing it does. First it reabsorbs sodium and gets rid of acid to reclaim the filtered bicarbonate, because you got to do that. Yep. And then there's one of your favorite transporters is going to be NAPI, the sodium phosphate co-transporter. And then there's the sodium amino acid co-transporter. And again, the most famous thing on the block nowadays is the sodium glucose transporter. And there are a couple isoforms in the kidney, SGLT1 and LT2. SGLT2Is we're going to talk about later because of their uses, but you can see immediately that an SG2 inhibitor, T2 inhibitor, is going to give you a natriuresis, so it's going to act as a natriuretic, and it's going to give you glycosuria, and that's going to act as osmotic.
Right.
So you're going to get the double loss of sodium and water in the sense of you have both a natriuretic and osmotic diuretic at the same time, and we'll maybe talk about that because that's a topic of its own now because of how famous they are, because they stop the protein to really slow down the progression of CKD, especially in diabetic kidney disease. So these are this is the paradigm for how the proximal tubule does what it does. Of course, what's not shown on this slide is the ubiquitous sodium potassium ATPase on the basolateral membrane. But one of the things that as a fellow, in Peter Aronson's lab, I said, his lab studies this transporter, and they were using an analog of amiloride, EIPA, to inhibit sodium proton exchange. And one of the things that was being used clinically, or not clinically, in the lab to block sodium glucose exchange was something called fluorazine, PHLORZIN. And fluorazine, I remember asking one day, maybe it was to Peter, well, wouldn't fluorazine be a good thing to use in diabetics? They would offload sodium and they'd offload glucose. And it turned out fluorazine was not very good. It was great in the lab, but it was not good to eat it because it didn't get reabsorbed very well, and it didn't really work like it was going to work. But all of the flozins, all the people that say they're flozinators, all of the flozins come from fluorazine,
right?
And that's why they're called flozins, because they come from fluorazine. So it was the idea was right. It wasn't practical at the time, but again, here was an idea that eventually went someplace. It went to a pretty important place, it turns out.
For sure.
So idea was right, but the timing was wrong. And timing is everything in comedy. So now that brings us to, well, what's going to be our natriuretic in the proximal tubule? It's the carbonic anhydrase inhibitors. And as shown in this slide, carbonic anhydrase is all over the proximal tubule. It's in the brush border, of course. Some of these are different isoforms, but they're in and out of the cell because of this important work. So when you give a carbonic anhydrase inhibitor, it's going to basically cause these reactions to not go like they would go. It slows everything down a little bit, and so sodium won't get as much reabsorbed, and you'll lose some bicarbonate. And this is why, of course, this slide shows you the immediate causes. These promote natriuresis by inhibiting the carbonic anhydrase in the cell and in the brush border. It's gonna cause a bicarbonaturia, which is basically, as Peter Aronson, I think, used to say, proximal renal tubule acidosis in a bottle. And that causes the metabolic acidosis. And, there's going to be some K loss, leading to some amount of hypokalemia.
That non-reabsorbable anion getting into the distal tubule.
Right. And so the efficacy, there's a natural break on this system, because as soon as you dump enough bicarbonate, if the filtered load goes down, then even in the presence of the inhibitor, you can now reabsorb what you're filtering again, and you come into a new steady state. So this used to be glaucoma medicine, and we see a lot of elderly folks with glaucoma on Diamox, and people would use it for altitude sickness and whatnot.
Right.
And because the metabolic acidosis makes you stimulate breathing. And so once the filtered loaded bicarbonate can keep up again, you're in a new steady state. So we used to see people whose total CO2 would go from 24, 25 to 18, 19, 20 and stop there.
Which is funny now that we know metabolic acidosis is not good for the kidney either.
Well, so the kidney knows what it's doing.
Right. Exactly.
The kidney has never been a big fan of drugs.
Right. Exactly.
So drugs and doctors and hospitals we talked about in the AKI session, not the kidney's favorite thing. So because of this natural quote breaking phenomenon, it's not the same as the breaking phenomenon that Dave Ellison talks about when he talks about diuretic resistance and stuff like that, which is going to be another topic maybe.
Yeah.
And Dave was also, he's the thiazide co-transporter maven, and I met him as my first attending at Yale.
I love it.
When he was at the VA. So again, this is very close to my heart and kidney, because these are all, these are more than transporters to me. These are my friends.
Yes, that's for sure.
So with carbonic anhydrase inhibitors, the overall diuretic effect is weak. And it's used, like I said, in glaucoma, altitude sickness. And, the ICU likes to use it in those patients that get metabolic alkalosis. And I've used it clinically to try to stave off dialysis in a patient with AKI. If somebody's going to be dialyzed only for hyperkalemia, or let's say sometimes a surgeon would say, well, you got to dialyze this person before I can take him to the OR because of the hyperkalemia.
Right.
Well, sometimes what you can get away with is the combination of giving acetazolamide, a loop diuretic, and fludrocortisone. That can get rid of a lot of that can get rid of a lot of the K if the kidney's still in the game.
If it is in the game.
If it's in the game, and it's worked.
But now with the potassium binders,
and
you have new tools.
But again, yes, but those right, and they got new tools.
Yeah.
But back before we had, the
it was
potassium.
a method.
We used, if the kidney was working, but you're right, the potassium binders don't need the kidney, and so that's another. It's just another way we can have people go to the OR without needing dialysis first.
Right.
Okay. Because coming out of dialysis, if you're sick enough to need to go to the OR emergently, dialysis ain't going to do you many favors.
You're trying to say dialysis isn't good for you.
I'm saying that the steady state it's good for you, but acutely
true.
it's again, anything acute
is flux.
Anything acute. So then we get to the one mutation of the proximal tubule I'm going to talk about, and this was actually very interesting timing because it was just before I was coming to Vermont in February of '96. I remember my last days at Yale. This paper came out in Nature, which was the common molecular basis for 3 inherited stone diseases. And it turned out that this was due to mutation in, at that time, kind of a new chloride channel family that was originally cloned by Thomas Jensch, the CLC5 chloride channels. And these are intracellular chloride channels. And what they do in just the idea is intracellular chloride channels are needed with intracellular lysosomes and other intracellular organelles that acidify. Okay. So when they're pumping protons, they need some shunt chloride conductance. And it turns out that these are them. So the surprise was that all of a sudden, what does intracellular acidification have to do with kidney stones? Well, it turns out that intracellular acidification is very important for being able to reabsorb certain proteins that are filtered. And if you don't reabsorb those, these are not the albumin proteins. These are things like beta-2 microglobulin and retinal proteins, retinoid proteins. And it turns out that low molecular weight proteinuria was a feature of inherited kidney stone disease. So here was the studies from the Nature paper. And of course, in Nature, they have these very multi-panel figures. So here's just the voltage clamp. This is just oocytes that are expressing one or the other of these RNAs. So oocytes that were injected with the wild type CLC5 and kept in sodium chloride, you see this beautiful outward rectification chloride current. And when they substituted some iodide for some chloride, the currents decrease, showing that chloride goes through the channel better than iodide, which I think is different than the anion selectivity of things like CFTR. So, and again, here's the great finding. Mutant oocytes injected with mutant CLC5, and these were the mutations that were in the patients.
Right.
There's no currents.
Right.
And they actually looked worse than the water-injected oocytes. So the summary IV plot shows that here's the outward rectifier wild-type channel, and here's the mutants doing not so good.
Amazing.
And so the loss of this conductance, which is an intracellular chloride conductance on the lysosomes, leads to kidney stones. And so that's it for the proximal tubule.
Yeah.
Done with the proximal tubule.
That's amazing.
We've talked about the physiology, we've talked about the diuretic, and we talked about the mutation. And that's our paradigm.
Segment 1 done.
Segment 1 is done. So here was a beautiful review that came out in Cell in 2001 from Rick Lifton. And this was after his lab had basically cloned, and we'll show you all those in detail, that all the monogenetic mutations that altered blood pressure, and I mean altered blood pressure either higher or lower, are all linked to the way that the kidney handles sodium.
Right.
So in their caption of this figure, you see that that sodium reabsorption by the kidney was, and whether that was affected by something intrinsic to the kidney, like a transporter, or whether it was an effect of the renin-angiotensin-aldosterone system, it's going through one of those. And he basically made the statement: all inherited and acquired forms of hypertension share increased salt balance as a inciting factor. So let's see about that, and that's what we're going to talk about.
Yeah, and that really lays out like for the rest of the talk, because we're into the major segments.
Yeah, we're beyond the proximal tubule, and all these things are beyond the proximal tubule.
Okay.
So again, here's what we're going to be talking about. We have the loop of Henle. We're going to talk about, you're going to see a bunch of these slides, and you see all these transporters, and it turns out that all of them can develop mutations. Then we're going to talk about the DCT, and the main thing that develops mutations here is the thiazide-sensitive cotransporter, NCC. And then we're going to get to the collecting duct where ENaC, as you notice, what we're showing here again is that each segment can reabsorb sodium, but in a slightly different way and for a slightly different reason. So why does nature choose the triple transporter here and only the double transporter here? Well, it's interesting at first, but then you realize the kidney really knows what it's doing. And then here it picks a channel.
And it ties in with what we talked about before, which was our countercurrent discussion.
Exactly. And so ENaC is important to say, and I'll say it a couple more times. ENaC is the rate limiting step for sodium reabsorption in the collecting duct.
Right.
Okay, so that's a very important, and that's the channel. So these are, sometimes people call co-transporters channels. They're not. This is a this is a triple co-transporter. This is a double co-transporter. This is an ion channel.
Right.
They are different. So here is the New England, one of my favorite diagrams of the
beautiful picture
of the transport elements in the thick ascending limb, and NKCC2.
Our active transport segment.
Yeah, where here's the active transporter, and then you see these elements, and there's a triple co-transporter, there's a potassium channel here, there's chloride channels here, and again, from an electrophysiology point of view, the blood is always ground, so if you take an electrode, it's going to be reading 0 millivolts here, then you poke into the cell, it's going to be reading minus 70, and when you come through the other end, it's not going to read 0 again, it's going to read positive 8 or 10, the transepithelia potential is positive 8 or 10, and that's because you got positive charges coming out this way and negative charges going to ground. That separation of charge generates a voltage.
And the triple co-transporter is electroneutral.
Yes.
So then your potassium leak is what's creating that positive charge.
Along with the chloride going the other way.
Okay.
Yeah, and so you get this, so that creates what we call a driving force.
We love it.
And the only reason you bother making a driving force is if there's a permeability somewhere, and it turns out that Dave Simon and Rick Lifton's lab worked out the permeability and called it paracelin 1, which is actually Claudin 16, but back in the day it was paracelin 1 when they cloned it. And this turned out to be cloned because of families they had accumulated who seemed to have genetic hypomagnesemia, pretty severe, and basically they lacked the permeability. So this is like nephrogenic DI,
right.
but of here where magnesium is going to get wasted rather than water. Okay, so we're talking about in that detail. So we come to the loop of Henle, and part one is because we're talking about the apical sodium potassium 2 chloride co-transporter. And this is the classic co-transporter that everybody who's ever given furosemide, it tries to block. And mutations of this, it turns out, causes what's called type 1 Bartter syndrome. Bartter syndrome is called Bartter syndrome because Frederick Bartter described it in the 60s. We'll go over that. As it turns out, having type 1 Bartter syndrome is like being born on a loop diuretic, but the loop diuretic never goes away. It's a loss of function mutation.
And it's even having it before you're born, antenatal.
Antenatal. And that's why and Bartter syndrome presents early in life,
right,
as opposed to Gittleman, which we'll talk about, which presents later in life. So we all know from giving furosemide what we would expect in type 1 Bartter, that you'll get some volume loss, you'll get some potassium loss, and you'll get a metabolic alkalosis. This is inherited hypokalemic metabolic alkalosis. And because you all of a sudden now decrease that driving force, you're going to waste calcium and magnesium. And so here is the original paper for the thick ascending loop where loop diuretics work, Bartter syndrome. Hyperplasia of the juxtaglomerular complex with hyperaldosteronism and hypokalemic alkalosis, a new syndrome. Well, it was new because it was 1962.
Amazing. And
this is, and Frederick Bartter was at the NIH, I believe, for most of his career. And this is a classic, obviously, paper. So let's take a look at that. So a good 30-something years later, Dave Simon, in working with Rick Lifton lab in 96, published that Bartter syndrome, hypokalemic alkalosis with hypercalciuria, is caused by mutations in the sodium potassium 2 chloride co-transporter NKCC2. And so what they found is families, and most of the families, as I recall, most of the families, but not all of the families, had this mutation. But the question was, wait a second, how come there's still families that aren't explained by this? And so Dave, who he had a spectacular fellowship at Yale, they went back and they looked back at the physiology of the loop of Henle, and they said, okay, we got this one, but maybe there's a problem somewhere else. Mm. So they rescreened the families that didn't get explained by this and looked to see if there was something wrong somewhere else, and boom. you're going to see. So in the loop of Henle, you need this, like you mentioned, you need this apical K channel to allow K to recycle. It's ROM K, and it's responsible for the lumen positivity, which is the driving force for the reabsorption of calcium magnesium. And it turns out that mutations in this lead to type 2 Bartter syndrome with the same exact kind of consequences. And here's the paper. Just a few months later, in the same 1996, here are the same authors, essentially, genetic heterogeneity of Bartter syndrome. And is there an R missing? Is there a T missing?
Yeah, there's a T missing.
Yeah, so so somehow or other nature.
It's
maybe this is the British spelling.
Wow,
it was
maybe
1996. So there's a little typo there. So this is not my typo. This is the website.
Yeah. Good pickup.
Mutations in the K channel. So they got to go back and fix that typo because Fred Barter didn't spell his name like that. That's not Bart Simpson. And so here we are here. So so now there were the families, most of those families with this mutation, and then there were some families with this, but they had some families left over.
Yeah, so we've completed all the little parts of the apical membrane that could be disordered.
Right.
Right. So
where would you go next?
Next is the BLM.
The basal adenovirus, our favorite. And so they went back and turned out that those chloride channels on the basolateral membrane, which allow chloride to be reabsorbed, and again, also contribute to the positivity because of separation charge. It turns out that, boom, a year later, in October 1997, and that they fixed the 2 T's, that there was mutations in the chloride channel, and it was the B1. There's like an A1 and a B1 channel, 2 different chloride channels, and it was the B1 that other families with Bartter syndrome had. And they figure, okay, we must be done now. There can't be any other families left, but there were. Okay, so now what? Okay, so this was okay in those families. This was okay in those families. This was okay in those families, but there was something else. And so it turns out that another person I met at Yale, Friedhelm Hildebrandt, worked with Thomas Jentsch, who was in Germany, and they found out that there was another form of Bartter syndrome, because the Bartter syndrome folks who weren't explained by the first 3 mutations had Bartter syndrome and also had deafness. They also had hearing problem. And it turned out that was because Barton is a beta subunit. The chloride, these CLC chloride channels needed this beta subunit to work. And it was also a chloride channel in the ear that needed it. So it turns out that these Bartter syndrome folks had congenital deafness and they had kidney problem. And the kidney problem was pretty bad. And so they showed here that Barton, and they named it Barton. I think Friedhelm told me they named it Barton, obviously, in kind of to honor Frederick Barter, whose name had been misspelled, but now is so this seemed appropriate, and so you get type 4 Bartter syndrome if you don't have Barton, because it's going to affect both of those channels, and you're also going to get the hearing problem. So here's our same diagram, showing now that this is fine and this is fine, and the chloride channel itself is fine, the alpha subunit is fine, but both of these chloride channels need Barton to work. And if Barton doesn't work, not only do these 2 chloride channels here need it, but the ear needs it too. And you're going to get the kidney phenotype, and you're going to get the ear phenotype. And people had always said classically that the people with kidney problems sometimes had ear problems, and vice versa. And this is no accident. It's because these transporters, nature built transporters and puts them in more than one place.
Right.
And when they're mutated, you're going to see problems in both places. So here's just an expression of this is data from those guys showing that Barton is the beta subunit required. And so here's your what happens when you don't have Barton. And when you don't have Barton, essentially what they show is here's current with the wild type and all that. But if there's no Barton, there ain't no current. So these are the currents of CLC, KB, and KA, and this is what happens. If you don't have Barton, no current for this one, and only a little current for that one. So you really need that beta subunit, which makes sense. Half the channel's not going to work. So this just shows you, fine, good. No Barton, not good. So currents, not currents. And so that kind of nailed that Barton was the beta subunit. And of course, because it's also in the ear, you get the deafness. So then, once they had Barton in hand, they could outline that not only was it in the thick ascending limb, turns out that the distribution of Barton kind of everywhere. So it's in the thin ascending limb of Henle. It's in the distal tubule. So it's all over the loop of Henle, the thin and the thick.
And it's in the apical and the basolateral membrane.
So it's going to be where the chloride channel is going to be.
Wherever the chloride channel is. Because it looks like in that picture, there's a lumen picture where they have Barton.
Yeah.
Oh, they might have a question mark there where they think it's playing a role in chloride click K17.
Yeah. I mean, this is just sort of, and there's more data you can get on this.
Amazing.
But it shows that Barton itself likes to be where, it's part of the chloride channel. It's its buddy that wants to be there. So that's Barton.
When I was watching a special, they had a conference and Dave Ellison was part of it. And I took a few notes and I was watching him. And he made a couple of key points.
What did he say?
With type 4A, 4A and B, he said the Barton form, he was like, this is the most severe form that they see.
Yes, it's the most severe.
Comparatively.
Yeah, it's severe for the kidney and also severe. So there's something about the basolateral. So Bartter syndrome, we've seen, is basically screw up any transport element in the thick ascending limb and you got yourself Bartter syndrome.
Yeah.
But that being said, if you're going to pick your form of Bartter syndrome, I might pick, maybe the ROM-K type 2 rather than... always looking because what happens with when these basolateral chloride channels are involved, not only do they get more severe kidney phenotype, and they also get kidney stones. Mm-hmm. They get the hearing thing.
Right. And the other thing that I picked up from that conference, a couple of great people spoke. I'm trying to remember, there was a few young researchers,
good.
But they were basically that, the type 1 and 2 were really the antenatal form.
Yeah.
But type 3 was the most varied kind of clinically.
It's really heterogeneous. And I think the reason for that is this slide may be helping us understand that, because Barton and these chloride channels are more than just the thick ascending limb. See, Barter's 1, 2, and 3, they're just the thick ascending limb pretty much.
Right.
But Barton is more.
Oh, yeah. Right.
So maybe what DHE was what Dave Ellison's initials are DHE, and everybody knows him as DHE.
That's funny.
It's his Twitter handle.
I love that.
DHE kidney.
That's awesome.
He's one of the greatest. And so I think that when you have Barton, I think when he was making that point, that conference, is maybe they made the point that Barton is in more places than just the thick ascending limb.
And then I found one other thing, which is, we haven't gotten to it yet, but you're about to. So.
Okay, so now we got to be done, right? There can't be any more.
No, there can't be. We've hit 4.
Yeah, we've hit 4. But there's a part 5.
Okay.
So the part 5 is there's a thing called not a transporter, it's a receptor. Calcium sensing, the famous calcium sensing receptor.
And I got to tell you that in my preparation for this, this leads to my favorite segment that I think has improved me in terms of reviewing things. This is the most interesting topic I found of the whole thing.
And I think you're going to be handsomely rewarded when you get 0 board questions right because of it.
So true.
Yeah, no, I mean the big reward is what you've already gotten.
I've already been rewarded.
Yeah, I don't know if they'll go in. I would love to see a Barter's 5 question on the boards.
Oh yeah,
and it belongs there because the calcium sensing receptors are what you're going to see is pretty
amazing.
Important. So it turns out, and this is again an example of when the kidney does exactly what you'd want the kidney to do.
Okay.
So the way it works normally in people that have normal physiology is that hypercalcemia, which can be caused, let's say it's caused by a malignancy. All of a sudden there's a, PTHRP or whatever you want to say. Hypercalcemia gives you a Barter 2 like physiology. And that's exactly what you want. So what happens is when the calcium sensing receptor is stimulated by hypercalcemia, it's on the basolateral side, so it's sensing the blood calcium. And when the basal calcium sensing receptor is activated, it basically inhibits ROM-K on the apical membrane through the P450 heat system.
It's a G protein coupler.
Yeah, and through its signal transduction, through, and I'll show you some of the signaling, through arachidonic acid-ish things and P450 whatnot. It basically is like having a Barter's 2. It puts a brake on the apical ROM-K channel. And that's a Lasix effect. It's a furosemide effect.
Which then leads to an electrochemical change in the lumen.
Right. And that's going to give you it's going to help offload calcium.
Right.
So that's going to decrease the driving force, make the lumen less positive.
Right.
Make calcium less likely to go through parasolemn.
Right.
And therefore, offload calcium.
But I think that's such an interesting thing because it's like calcium on the blood side hits the basolateral membrane.
Yep.
And then through signal transduction, it changes the electrical driving force for calcium, and that's how it impacts calcium excretion.
Exactly.
It's not like specific.
Right, and it's membrane crosstalk.
Right.
Because the basolateral membrane is where the sensing receptor is, but the apical membrane is where the effect is.
Right. Amazing.
So the physiological role is to decrease calcium resorption in the thick ascending limb, and I go into this in a little bit, in a couple more slides.
Cool.
So here is Ed Brown from Harvard, and I think Ed Brown and Steve Hebert, when Steve Hebert was at Harvard before coming to be the chair of physiology at Yale, cloned the calcium sensing receptor, and one of the things they found is it's pretty darn important, meaning that it's in a lot of places. So it's where you'd expect it to be. It's in the parathyroid.
Right. That's where they cloned it initially, right? The chief cells of the parathyroid.
You may be right.
Mm-hmm.
And again, here are the biological effects. And I can't. It's too small for me to read. So go ahead, Craig, and read some of these things.
They were at Harvard when they did this because I remember when I was reading one of the articles.
Yeah, they were. Harvard. This is Harvard work. Yep.
So P1 transport. Yep, phosphorus transport.
One of your favorite things.
Yes. Vitamin D synthesis, 125-OH.
Right.
VDR expression,
right.
vitamin D receptor expression, urine acidification, sodium chloride, calcium mag transport. Calcium
in the thick
mag
ascending
transport
limb, right?
decreases. Yep. Decrease in sodium chloride, calcium, and mag transport. That was for NKCC2. It had, in each of the different segments,
right.
It had all these different effects.
Right.
So.
And then look what happens in the collecting duct.
Yeah, so in the collecting duct, you have an increase in the hydrogen ATPase and urine acidification.
Yeah.
And then in the outer and inner medulla collecting duct, you have AVP dependent aquaporin apical insertion.
Right. So hypercalcemia acts in two parts of the nephron at least. So what it does is now that you're not reabsorbing that calcium in the thick ascending limb, that could increase your risk for kidney stones. Okay. But what happens is the same hypercalcemia through the calcium sensing receptor interferes with trafficking of aquaporin 2 to the apical membrane along the collecting duct. So you've got a little bit of this is the classic nephrogenic DI of hypercalcemia. So the kidney is so smart that not only does it know to offload calcium into the urine and not reabsorb it in the thick ascending limb, it knows that may be a risk for stones, so it adds more water in the collecting duct. So that's an anti-stone effect. So here is their diagram. This isn't the angry nephron that we saw last time, but this is the nephron in the different colors
in the different segments.
show the apical or basolateral expression of calcium sensing receptors, and you see, I think in the proximal tubule, I think it's pretty much all in what I think is the apical membrane, whereas here it's on both sides. So you see, it's just so interesting. But the calcium sensing receptor is all over the kidney.
Oh yeah, it's ubiquitous.
So I mean, the kidney. If you think the kidney is not paying attention to calcium, here's a slide that tells you
it's probably the most.
It's paying a lot of attention. So here in another table from that review paper by Ed Brown. It shows again here that here's Bartter syndrome type 5 when there, instead of a loss of function mutation that we saw with the transporters, there's a gain of function mutation.
It's as if you're hypercalcemic without the hypercalcemia.
Yeah, you're shifted over.
Right.
And here's what happens to you. What does that say?
Hypokalemia, hyperreninemia, and hyperaldosteronism.
Yeah, it's Barter's type 5.
Right.
So here again is just a little diagram that shows you at the different places where the calcium sensing receptor is, what it does. Increase phosphate reabsorption, decreases calcium reabsorption, increases proton secretion, acidification. It must be a good reason for this, and decrease water reabsorption. So this and this work together so you don't get the kidney stone. So here is sort of the physiology of some of that. Here's the interfering with the aquaporin insertion. When you
they said that, I remember seeing something about trying to link divalent excretion to a hypotonic urine.
Yeah.
So that you reduced it when the urine became more concentrated.
Exactly.
Right.
So here's just here's the again, now here the calcium sensing receptor is luminal. So here we're in the collecting duct. So it's luminal, not basolateral like it is in the thick ascending limb, and it's interfering. What you see here, that when there's hypercalcemia, there'll be less trafficking of aquaporin too, so water will not be reabsorbed. And here's the effect on phosphate.
Okay. That's awesome.
So I think these are interesting things. Of course, you need when you're changing driving forces, there's some permeability. So claudins are involved with this too. So this just shows you how complex the calcium sensing receptor physiology is across the nephron.
That's a whole talk on its own.
It's in different places. Sometimes apical, sometimes basolateral, doing different things.
But I think it's an awesome overall concept that calcium regulates our salinity management. I mean, our salt and water balance.
Right. There's a nice paper by Steve Hebert that shows, I think it's called something like calcium sensing receptor regulating salinity from mammals to not mammals and back.
Yes.
And this was probably the important point of our being able to get out of the ocean.
Yeah. Right.
So all of these things had to happen, and the kidney does it all. But again, if you ever wonder, well, I don't know exactly how it works, I don't remember. You don't need to remember. Just say, what would you want the kidney to do?
Right.
Okay. What would you want the kidney to do with hypercalcemia and aquaporin? You'd want it to not put channels in, and that's what it does.
It's amazing.
So it is amazing. So again, here is kind of again showing more of the same, just showing the signaling here in the thick ascending limb, and here is I'm showing you the some of that signaling. So the calcium binds at the basolateral membrane, and you see it's having effects through both pKa and phospholipase A2 through arachidonic acid, which we know, and we use arachidonic acid in the lab to inhibit K channels, and our basolateral potassium channel in the proximal tubule was inhibited by arachidonic acid, and again, it does it here too. So arachidonic acid metabolism involving especially 20 heat seems to play an inhibitory role on the potassium channel. And again, this is going to give you a Barter's type 2. So it's type 5 Barter's because it's a different protein. But it's having type 5 causes Bartter syndrome like type 2.
Right. And it'll still probably have the same phenotype.
Yeah.
A similar phenotype.
Yeah. Probably. So here's kind of all this blown up. Here's the thick ascending limb, and you see that sodium, calcium, magnesium are all being reabsorbed by that positive voltage driving force. Here is the NKCC2 mutation in type 1. Here's the type 2 in K recycling. Here's the type 3 with this chloride channel. Here's the type 4 with the Barton. And here's the type 5 with the activating mutation of the calcium sensing receptor.
And I saw one other when I was reading, and they listed it in a 5, but I'm not positive. I'm going to have to get the article and send it to you. But it was this MAGE, MAGED2 protein that regulates, it has to do with inserting NKCC2 into the membrane and NCC. So it did both.
Right. But if it happened after 2004...
It was 2018.
Yeah, well then...
They should have called it 6.
I think they should have, because 5's already taken. So so here is this thing we were talking about, the calcium. This is taken from Steve Hebert's review in the KI in 2004. So this is already being reviewed in 2004. The calcium sensing receptor as a salinity sensor. In the thick ascending limb. So this again, he talks about the evolutionary physiology of how, the fact that the serum calcium somehow interacts with how saline is handled it's very beautiful, and just shows the kidneys paying attention to all this stuff for a pretty long time.
And the calcium sensing receptor is an unbelievable thing. I mean, I was so impressed by that, the fact that we have this receptor that can sense an ion concentration.
Yeah.
At millimolar concentrations at its physiological level, with very tight regulation, like a steep activation curve. Like if it changes a little bit, this thing
Right. The operating
functions.
region is very sensitive.
Yeah.
And made you ask the question, well, wait a minute, if nature could make a calcium sensing receptor, why aren't there everything sensing receptors?
Well, in some case, something is feeding back with these things.
Yeah.
The question is, what is it?
Yeah.
This is at such a level.
Yeah.
It's not a global level. It's not like our volume management or other things.
Right. And I don't know if there's a phosphate sensor.
I want to know.
But if there was, then I think managing hyperphosphatemia and secondary hyperthyroidism in our dialysis patients and CKD patients would be a little simpler if we had a drug.
I mean, we know for a fact calcium sensing receptor has to do with our phosphorus management too, because it regulates one of the most important regulators, which is FGF23.
Right. But what's difficult for students, and not just students, everybody, is that there's always, depending on where you start, when you start talking about calcium and phosphate, you quickly figure out that you got to know where you're going to start. Because wherever you start, because of vitamin D, calcium and phosphate, clotho, FGF23, all these transport, you really get into
a quagmire of
you
feedback.
do. Like, oh my God, what's going on? And so, but I think that the reason it's so complicated is because there are different control points, and some of them work through sensing receptors like calcium.
Mm-hmm.
Some of them work through hormones like vitamin D.
Yeah.
And these are more complicated because some of those work by clotho and FGF23.
Mm-hmm.
So it does, to me, I feel less bad about not understanding
Phosphorus regulation.
Phosphorus and vitamin D, because it is complicated. I mean, and nature had a reason for doing this, because nature could have probably made these sensing receptors, but there are other priorities.
And I think the other thing is that we always try to separate out each of these things, but there's so much overlap in these systems.
Yes.
And these are processes that are utilized in many different epithelial type cells.
Yeah.
And when you get a disease or a genetic disorder in one, it impacts multiple things, which we see with hearing loss in the ear.
Well, I think some of this becomes a game like the balloon. You squeeze the balloon down here and it bulges over here.
Exactly.
So there is some of that.
Right.
It goes on. So here's just a big blow up that I think shows here's the thick ascending limb, and how the signaling works with all the players here and hormones. And again, you see the lumen positive voltage is important. And so this just shows, here, it goes into what we talked about with countercurrent and the water being rejected here. All these things have to be going. The kidney has to be doing all of this while it's also maintaining countercurrent, all the other stuff we talked about.
And that was the other question was if you have barters, do you lose your diluting ability?
I think to some extent you do, because if you have barters, it looks like you're going to be on furosemide.
Right.
Right. So, I mean, we give furosemide to decrease the tonicity of the inner medulla.
But when I was listening in on this conference, they really said that some of these kids with antenatal severe Bartter syndrome actually they could concentrate their urine to 1200, 900, 1200. They didn't lose it.
Okay.
And then Dave Ellison.
They're pretty young, though.
They were young.
Yeah.
They were pretty young.
Yeah.
And then
so they might be. The question is that they got pretty concentrated, but they get as concentrated as kids that don't have it.
That's a good question.
Yeah. So I mean, I believe that I can no longer do my concentration what I used to do because I'm older. So if your point is that the kids in utero and beyond, they could still do a pretty good job, but how are they doing compared to their peers?
And the other part of that is that polyuria that they have is not this hypotonic polyuria, like because they've lost their medullary concentrating ability. It's a salt diuresis.
Right. And they've got a couple of reasons to have polyuria. They got both the solute and water diuresis. Right. So it explains a lot. But again, clinically, you can decide to just remember it all clinically, or you can learn it physiologically
and then work back.
And just know when you're stuck, the kidney does what you want it to do most of the time.
And a good point is that some of these specialists are so good, they can make these diagnoses pretty much on a clinical basis most of the time. Yeah. But now they all are doing genetic testing, and they feel that that's an important part of the workup for these.
Right, because you never know when you're going to see a nuance.
Right.
I mean, at first, Bartter syndrome was just one homogeneous disorder.
Right.
And now, according to you, there's 6.
Yes, right. And I think they're trying to change the name of it because people call them Barters or Gittlemans, which you're going to talk about.
Yeah.
But really, these are the salt-losing tubulopathies.
Yeah, they're the salt-losing tubulopathies. Yeah, I think that's right. So here's just a review slide to show that hypercalcemia, I mean, there are more people with hypercalcemia than there are with Bartter syndrome. Bartter syndrome is pretty rare.
Yeah.
Even though there's 6 kinds of it, Bartter syndrome, it's rare.
I haven't seen 6 people.
Well, I mean, and again, adult nephrologists aren't going to see it.
That's right.
This is a peds nephrology thing.
That's right.
Because those, the Gittleman's kids, they present in adolescence because their hypokalemia makes them weak when they go off for intramural sports.
Right.
And they come home and go, I can't keep up with the other kids.
Mm-hmm.
They're not having the right out of the uterus, and I'm having a problem. Whereas the Barter's kids, especially the severe ones,
right,
if they're deaf, it's right out of the uterus. So here's a slide that shows again, and here I put a ground symbol in to show that the blood is ground, that the lumen is 8 to 10 millivolts positive, and then here's all of our, at least the 5, I don't have
players.
The 6 one, all the players, and that hypercalcemia leads to polyuria in the sense that it decreases calcium reabsorption, which decreases urinary dilution. But then you've got this aquaporin effect along the collecting duct, which dilutes the urine. So it's undone here.
Yeah.
And so it's beautiful.
Mm-hmm.
And so type 5, again, is the exception being a genetic gain of function of the calcium sensing receptor rather than a loss of function. All the rest of these are loss of function.
Right.
And I don't know about number 6, but was it a loss of function?
Nope. It is a loss of trafficking the NKCC2 and NCC into the membrane.
Right, but it integrates as a loss of function.
Yes,
okay.
It integrates as a loss of function.
Okay.
Oh, one other thing with the calcium receptor with the gain of function, that's also familial
it's got name.
Hypercalciuric, hypercalcemia,
Yeah.
hypocalciuric.
I think that I could be wrong about this, but I think that the way that Brown and Hebert cloned it, this was back in the days of positional cloning, was by collecting families. Yeah. I mean, all of the stuff that we've seen that the Lifton lab has done, this was done in the 90s and the early 2000s when most of it was done by positional cloning and collecting families. So anyway, that's the review slide for the Barter.
Awesome.
Okay. So here is again, the recapitulation of the 5 mutations that I know about.
Mm-hmm.
I don't know about the 6th one, but here they are again. So again, this would be a slide you look at if this stuff ever was on the boards.
This is your slide.
This is your slide.
This is your
for the
slide.
Night before the board. So the good news is I reviewed this slide. The bad news is they didn't ask me any questions on it. And now you can I think on the boards, at least when you take the test, the real test, not the take-home test, but the real test, you can have. You can write notes electronically in the margin, so to speak. And I used to, when I saw like questions on thiazides, I used to say, Dave Ellison, is this you? Is this you, Dave?
I love it.
Because I got this right because of you, or I got this wrong because of you.
Right.
Okay. So now we're going to get to the pharmacology of the loop diuretics. And the loop diuretics, in general, they're highly protein bound, so they don't get in through GFR, through the glomerulus. They get in because they go through the organic anion transporters in the proximal tubule. That's how they make their way in, because they have to work on the apical side.
Mm-hmm.
So again, we talked about the furosemide stress test. It's first of all, the furosemide has to get in. May have a problem getting into the proximal tubule. The proximal tubule is dead.
If you have no proximal,
if the proximal tubule is fried. Dead, right. Once it gets into the proximal tubule, it's got to make its way to the thick ascending limb, to the apical membrane, and that has to work. And so you can flunk the furosemide stress test any one of 4 places. You don't get in. You get in, but you don't get to the site. You get to the site, but it doesn't have the effect because the transporter doesn't work. So so this is how these work. The diuretic activity is also due to enhanced PGE2. Here are our drugs. Furosemide, better known as Lasix, because it lasts 6 hours apparently. Bumetanide, Bumex, which is 40 times more potent than Lasix. So 1 milligram of Bumex is 40 milligrams of furosemide. Torsemide, which is my personal favorite. Ethacrynic acid is quite expensive. Ethacrynic acid became famous because it was the one of these that you could give to people that were sulfa-allergic. So these are all sulfa, but it's a pretty much hidden sulfa. Right, okay. So you can have a sulfa allergy, but
you may not respond to that.
Lasix allergies are pretty unusual.
It's pretty rare.
I think I've seen it once.
Yeah.
I think I saw it as a fellow once, and I wasn't even sure, but we were calling it that. So Lasix lasts 6 hours. Bumetanide's 40 times more potent. Torsemide I like the best because it's longer acting, causes less hypokalemia, and it might have a anti-mineral corticoid. It might have a mineral corticoid receptor antagonist effect. So it may be a little bit more than a loop, and it's not associated with ototoxicity if that's a problem. And ethylenic acid is not a sulfonamide. So this is the loop diuretics. So the clinical use is exactly what we said. You want a natriuresis whenever you want to have decreased ECF volume in the edematous states, and these are your edematous states. So that's when you use it. Here's our picture again. I must be showing this for a reason. To probably remind you that, so, people sometimes think that the hypokalemia of loop diuretics is because this isn't happening, so the K is getting wasted. That's not really the hypokalemia. Hypokalemia is due to the fact that more sodium is going to make it out of the thick ascending limb. And so what happens is the hypokalemia is due, first there's the volume loss, which triggers activation of the RAS system.
Right.
And that's going to give you K loss via ROM-K.
Mm-hmm.
There's an increase in flow rate at some point.
Not ROM-K in the thick ascending limb, but the ROM-K
that's
in the
principal
principal
cells.
Cell.
I think that's why I said, you're right. ROM-K in the principal cells. Because it increases the lumen electron activity of the collecting, because ENaC gets stimulated.
Right.
And so again, the K secretion is also through maxi K channels can happen, and the increased luminal sodium delivery because there's more ENaC activity, especially because RAS is stimulated. Mm-hmm. And so that's going to lead to more K secretion. So the K secretion, like one thing that we like to remind people that a person who's vomiting doesn't lose their K in the emesis. Right. They lose their K because the kidney is where it's lost from the secondary hyperaldol. And ENaC is stimulated by that, and so whatever stimulates ENaC is going to increase the lumen electronegativity, increase the driving force for K secretion through ROM-K in the apical membrane of the principal cells. So this is where the hypokalemia comes from. Metabolic alkalosis, well, you're losing basically sodium chloride. So what's left is, if you lose a bicarbonate-free solution, then you still got your bicarbonate.
Right.
Also, hypokalemia promotes proton secretion through the proton potassium ATPase. I'll show you.
And also aldosterone stimulates that ATPase.
Yes. And also so in secondary hyperaldo. So metabolic alkalosis and hypokalemia sort of stimulate each other.
Right.
And the reason for that is here's our old.
Which is the same thing that you see in our Barter's patients because they're volume depleted, they're metabolic alkalosis and hypokalemia.
Yeah. So here's a cell diagram I made in a review. And so again, whenever you have increased aldo and increased sodium delivery, you're going to stimulate ENaC. That stimulation of ENaC, whether it's because of aldo or flow or whatever, it's going to increase the lumen electronegativity. Mm-hmm. This increases the driving force for K secretion. And as you just mentioned, aldo receptors are not only in the principal cell, they're in the alpha intercalated cell, where they do two things. They stimulate proton secretion through this proton ATPase. Mm-hmm. And there is another proton ATPase coupled to potassium reabsorption. So when you're hypokalemic, this thing is going to get turned on to try to bring some more K back in. When that gets turned on, so again, you can throw up where you lose your proton, you secrete your proton through the gut, or you could throw down where you lose your proton in the urine. So again, I used to joke with the fellows when they said, we got a case of metabolic alkalosis. And I'd say, was the patient throwing up or throwing down or both? Right. And they go, well, of course, both. Right. Because the throwing up leads to throwing down. Right. Yeah. So again, one of the reasons that, we talked about in the acid-base section, vomiting initiates, the loss of proton initiates metabolic alkalosis just chemically right away. That generates the metabolic alkalosis. One thing that maintains it is the hyperaldo state and the hypokalemia that maintain this going. So throwing up leads to throwing down. Right. Okay. It also explains why aldo, if you have adrenal adenoma, screening aldo, it explains why you're volume overloaded, hypertensive, why you're hypokalemic, and why you have metabolic alkalosis. So it's all there.
When you know these players,
I mean,
all you do is put your arrows in.
These may look like cell physiology diagrams, but they're at the bedside, baby. Yeah. These are pretty close to the bedside. Yeah. Someone should make a quilt. Yeah. For people in the hospital.
And this is how you can understand what's happening to somebody. You're seeing a patient. And you're trying to figure out what's the right medicine to use and which one of these things do you go after.
Right.
And do you block aldosterone? Do you remove a tumor? Do you block ENaC?
Yeah.
where do you go?
And my hypothesis has always been if you give fellows a physiological based training, they'll keep this with them because they'll always have the structure.
That's it.
It's like a closet. I used to tell the students, it's like what we're going to do is try to build closets. The clothes in the closet, some of them are going to get old. Fashions come and go.
Yes.
But if you got a strong closet, like those old colonial houses, you move in. Look at this closet made in 1791.
Yeah.
Yeah. So anyway.
Very cool.
So here are loop diuretics. Of course, we mentioned the calciuria and the magnesuria because of the loss of the driving force. And just a clinical reminder that K supplementation will not correct diuretic-induced hypokalemia unless you correct the hypomagnesemia, because body depletion of magnesium is going to interfere with the inward rectifier, K channels, and you're going to dump a lot of K because it's getting out of the cells. So that explains, everything is explained by physiology. So then I remember having a conversation with Dave Simon. We were at a meeting, we were in the Poconos, a transport meeting, and he was there talking about Bartter syndrome. And we had a walk. It was a beautiful place, and we had a walk. And he was telling me that he was looking at these families that had familial hypomagnesemia.
Okay.
They were magnesium-wasting people. And they got pretty sick. These kids at a young age get pretty sick. And he had collected these families. And we had a discussion about driving forces and permeability. And it turned out, he had already worked out a lot of the driving force problems with the transporters. But, in the late 90s, so I think we were at the meeting in 96 or 97, and then Science 1999, Dave, again, working in Rick Lifton's lab, found paracellin. And in paracellin 1, which is Claudin 16, is the paracellular permeability that allows magnesium, among other cations, to be reabsorbed in the thick ascending limb. And when they raised an antibody to it, they found here's an antibody staining tight junctions. Cludin is one of the tight junction antibodies in red. And then when they merged it with their paracellin staining in the thick ascending limb, they were on top of each other. Right. So it was really, paracellin was not, it was in the tight junction. It was between the cells. That's why they named it paracellin.
Right, so cool.
So here we are. We've been talking about the thick ascending limb, where we've talked about all these transporters and the diuretics, loop diuretics, and we talked about paracellin. And now we're moving into the distal convoluted tubule. So we've talked about this. So now in the DCT, where thiazides act, we're getting into Hillel-Gittleman. It must have known Izzy Edelman.
He had to. They were buddies.
They must have been buddies. And so this again was new, but it was
a new disorder.
New in 1966. And this is a journal that it's hard to get. Anyway, here's the headline from the journal. A new familial disorder characterized by hypokalemia and hypomagnesemia. And it turned out to also be metabolic alkalosis. And so Hillel J. Gittleman described this new thing in 1966, and it was a big deal in the pediatric literature. Mm-hmm. So let's just talk about thiazides for a second. So I just wanted to bring up the fact that there are, two categories of thiazide drugs. There's the thiazides themselves, like hydrochlorothiazide, and then there's the thiazide-like diuretics, like chlorthalidone and metolazone. And the thiazide-like diuretics, like chlorthalidone, you can see it's got a pretty long half-life. Mm-hmm. So I love my chlorthalidone. Mm-hmm. Now part of this is why they can cause more hypokalemia. And if you're a stone former, why is hypokalemia, here's a board's question, why is hypokalemia bad for a stone former? Why does hypokalemia promote stone formation? Do you know? I'm putting you on the spot.
You are putting me on the spot.
It's a board's question.
That is a board question. I might have gotten it wrong, but it's got to impact calcium excretion. Thiazides decrease calcium excretion.
Right. But they also cause hypokalemia. Right. And hypokalemia is bad if you're a stone former. Why?
Well, because of distal sodium delivery.
Oh. The reason.
Okay.
What's the main thing in the urine that prevents stones from forming all the time?
Citrate.
And guess what causes hypercitraturia? hypokalemia.
Oh, okay.
So when you have hypokalemia,
well, yeah.
you don't make as much urinary citrate.
Okay.
So as a person who takes chlorthalidone, who could get the hypokalemia, well, I also take losartan.
Mm-hmm.
So I mean that I keep my chlorthalidone is driving my K down, but my losartan is driving my K back up. So I'm hoping they meet in the middle. But I eat a high potassium diet for the reasons we talked about with the high K diet being cardiovascular benefit. But also, I don't want to get hypokalemic because as a stone former, I don't want to have hypocitraturia. My mentor, Fred Coe at the University of Chicago, would be very upset with me. So he loves chlorthalidone. He taught me early on as a little baby med student, you give your stone formers chlorthalidone if they got calcium forming stones. Mm-hmm. But you have to avoid the hypokalemia to not get hypocitraturia.
Okay.
And that I have seen that on at least, if
so
not on the
impacts
board.
citrate in the lumen.
In the lumen. So if not on the boards, I've seen it in board review. So it's one of the reasons that K-citrate is a great thing to give stone patients.
Because it treats both.
Exactly. Or at least it tries to. Mm-hmm. So most often used for hypertension. So I got bad hypertension that is bad if I don't take more chlorthalidone. And I love my chlorthalidone. And chlorthalidone was in all hat, which showed it was, nothing was really superior to it. But it's way, way, way underprescribed compared to hydrochlorothiazide. Now, it is a little bit more expensive, but not that much. But and I don't know if this is true or not, but my hypothesis always was that back in the days of paper prescriptions, it was easier for a doctor to write HCTZ than to spell out something with our horrible handwriting. And so I wonder if HCTZ got popular just because it had a cool abbreviation or an easy abbreviation. And then if you have people that have CHF, you can give, these like metolazone is our classic. You can really take off the volume fast. So again, if it's just hypertension, I like the chlorthalidone. The side effects are, hypokalemia and other side effects may be more common with chlorthalidone. I'm lucky. I took chlorthalidone and didn't have any effect on me except the good effect. But some people have trouble with it. But it's always my go-to starter. And if somebody doesn't tolerate it, then I might put them on HCTZ. So here's the clinical effects. The reason that thiazides, some of these side effects are good. The hypocalciuria, I remember talking to my friends in the Netherlands, René Bindels and Joost Herndrup. These guys are fantastic, and they, they're very big in the magnesium and calcium world. They're just awesome. I remember going to visit them in the Netherlands, and I landed at the airport in Amsterdam. I had pee. And I noticed two things when I went to pee. First of all, the urinal was so high, I had to stand on. I think it's the tallest country in the world.
That's so funny.
I think it's
either that or their penises.
I had to stand on two telephone books.
Oh boy! And
once I got up there, I noticed another thing that was cool. I thought there was a fly in the urinal, but the fly was actually engraved there. What they did, as a control systems person, I loved it. So they had done the study to show, because guys love aiming at something. So what they did was they engraved what looked like a fly, knowing guys would aim at it, and the fly is engraved at the point in the urinal that minimizes splashback.
I love it.
Okay, so I already fell in love with the country, felt taller when I got there, and this is at a time that they were working on the TRPV5 channel, which was the epithelial calcium channel in the distal nephron. So a lot of people were wondering, well, are thiazides cause hypocalciuria because they stimulate calcium reabsorption through TRPV5 in the distal nephron? And much to their chagrin, they wrote a nice science paper about this, I think. And I think you might have reviewed it in Journal Club. Somebody did. Maybe it was either you or Tobin. I think Tobin.
Yeah, maybe Tobin.
It's Tobin, because it was after you. I think it was 2005. So it turns out that that wasn't the reason for the hypocalciuria. It wasn't hyperreabsorption of calcium through TRPV5. It was because the volume depletion induced by thiazides stimulated proximal reabsorption of calcium, and that's why there was less calcium.
Funny. Unless
you decrease the driving force in the thick ascending limb, calcium's not going to really much go out because it's been reabsorbed. So it caused hypermagnesuria. Hypermagnesuria, which leads to hypomagnesemia in thiazides. Whenever you're working up somebody for hypomagnesemia, you got to look at that.
Right.
And again, I already noticed this. And then the glucose intolerance of thiazides, at least it's thought to be mostly secondary to hypokalemia. We talked about this. It's going to hyperpolarize the membrane potential of pancreatic beta cells. And when you hyperpolarize pancreatic beta cells, they decrease their insulin secretion. So possibly the glucose intolerance of thiazides is related to the hypokalemia. So if you avoid the hypokalemia, this is the key. Treat the hypokalemia, avoid the hypokalemia. Use an ACE inhibitor or an ARB. And then, of course, there's the gout concern of thiazides. Now, I love talking about this because I love talking about hypotonicity. So one mystery that people always wondered about is why do thiazide diuretics cause hypotonicity much more often than loop diuretics? So loop diuretics, because of what we talked about in countercurrent, they are going to affect, because the same step that dilutes the urine concentrates the interstitium. When you inhibit that, you're inhibiting both things.
Right.
So since you're inhibiting both water excretion and water reabsorption, it's kind of a wash.
Okay.
But thiazides, now you're back in the cortex, early distal tubule, that only impairs water excretion. So in the way kidney makes free water by removing solute. So if you leave sodium and chloride in the urine, if the thiazide-sensitive cotransporter was going to remove sodium and chloride, and now it doesn't, water that would have been made and stay in the tubule, because that tubule is water impermeant unless ADH
still in the distal, right?
It's going to show up in the urine, and water can only be in two places across an epithelium. It's either in the blood or it's in the urine.
Right.
If you didn't make it in the tubule, it's still in the blood.
Right.
So when thiazides block the reabsorption of sodium chloride, the water that would have been made in the tubule is not made. So free water can only be in two places. If it's not in the urine, it must be in the blood. So this is difficult for students to understand, I've seen. But again, once you think about an epithelium, if you didn't make the water on the tubule side, it's still in the blood.
Yeah.
Because
you're saying by making water, you mean removing the solutes.
Yeah, the kidney makes water by removing solute.
That's the diluting segment.
Yeah. That's why it's called that. Yeah. So anyway, here's a little slide that shows, and I think this was shown for the younger people are the white and the older people are the blue. So this is your water excretion capability. And so the placebo side shows that when you get older, you're not able to excrete as much water. And this is why older people have to can't become solute depleted to get hyponatremia. You can't put them on thiazides. And when you put them on thiazides, look what happens to the older folks. They lose the ability to excrete water tremendously. So here's the younger folks. Younger folks can't excrete as much water either.
Right.
But it doesn't become clinically relevant because they're not, But here, older folks, especially older folks who are eating a tea and toast diet, who are on a thiazide, really got to be careful.
Oh, yeah.
These people are a setup for hyponatremia. And hyponatremia, as we talked about, promotes everything from falls to breaking bones. And it's easier to break a bone when you fall. And so and we know that, hyponatremic patients die faster. Their mortality is higher for whatever reason, directly or indirectly. So hyponatremia is more likely with thiazides and with loop diuretics. So you got to watch yourself as people get older or lose water excretion ability. And here's just a nice New England Journal slide that shows the potential complications of thiazides across the spectrum of tissues. I won't read it to you, but I think you can see here somewhere in the pancreas, it says that there's a question mark here, right?
Impaired insulin resistance.
Yeah, is it from the potassium? The question mark is whether this is a link or not.
Right.
Is it really?
I see.
Is it the thiazide acting in the pancreas?
Yes.
Okay, and I don't know. Or is it this question
from
mark?
The low potassium.
So at least as far as 10 years ago or so, the question mark was still there. I like to think that because I think insulin secretion is regulated by membrane potential, which is regulated by channels. And so when the driving force in hypokalemia tends to hyperpolarize, I'll buy it, but I don't know if it's science. It's theory.
Yes.
I don't know if it's real. So we're talking about the early distal nephron. This is the apical sodium chloride cotransporter, which is, of course, DHE would call the thiazide-sensitive cotransporter, or NCC.
NCC. Yep.
Inhibited by hydrochlorothiazide. And mutations of this, as Hillel Gilman probably intuited back in 1966, mutations of this is like being born on a thiazide. It's Gilman syndrome, hypovolemia, hypokalemic metabolic alkalosis, and hypocalciuria. And this, it's when mutations, and these aren't direct mutations in the thiazide-sensitive cotransporter, but there are things that are mutated that lead to increased function of this transporter, and that leads to Gordon syndrome, which is essentially the mirror image. Instead of hypovolemia, there's hypertension. Instead of hypokalemia, there's hyperkalemia. Instead of metabolic alkalosis, metabolic acidosis, and probably hypercalciuria or not hypocalciuria. Okay, so here's the early distal nephron. I like this picture because it shows, here's the apical surface. Here's NCC. Here's, and this shows some of the magnesium things. What happens is there was a family of these folks found, I think the family was in France, where the apical voltage-gated KV 1.1 channel is located on the early distal nephron. And there was a family that had a mutation in this. And this mutation meant that they couldn't repolarize their apical membrane. So when sodium came across, they wouldn't repolarize as well. So they wasted magnesium. And so they had kind of a Gittleman's phenotype as well. And again, relating to magnesium is chemotherapeutic agents that bind to the EGF receptor lead to dysfunctional TRPM6. These are magnesium channels, part of the TRP Nobel Prize winning family of David Julius. And so again, you see that magnesium, the early distal nephron has effects on not only sodium and chloride reabsorption, but also calcium and magnesium reabsorption, which is why Gittleman's folks have hypocalciuria. And it was always hard for people to understand why, because we didn't understand all these transporters. Right. And then, we see people get tremendous hypomagnesemia with chemotherapy that affects the EGF receptor. And because this doesn't necessarily go away. So these are difficult patients to treat when they're wasting magnesium from the kidney. But it also shows, when Gary Desir and I were working with KV 1.3 in the kidney, we submitted a paper and everybody says, oh, come on, what would a voltage-gated K channel be doing in the kidney? Kidney's not excitable. Well, here you go.
Right.
So anyway, so much for, sometimes.
It's all timing, Alan.
Sometimes.
It's like comedy.
Yeah, it's all timing like comedy. So here's just shows, compares to the 5 types of barters. And here we already we showed that there's, type 1 barter is always NKCC2, but it's not just one mutation. There's a bunch of mutations. A lot of them on chromosome 15. There's a bunch of mutations on chromosome 11 that can lead to the BROMK problem. More than 17 mutations of this one in type 3. So there's a lot of mutations that affect these proteins and gives you the barter. Interesting thing about Gittleman's is, as opposed to the thick ascending limb where all the different transporters can give you barter if they're mutant, in Gittleman it's always the thiazide co-transporter. And last I checked, there was hundreds of them, like 400.
Wow.
500. And one of the reasons for this, Craig, is
this is a conserved gene.
Yeah,
there's some protective benefit to this thing.
There are places probably where these people are kind of protected from hypertension.
That's what I mean. They don't die. For some reason, this is...
So maybe these folks were dying off back in cholera days. Because,
right.
Oh, my God, I can't reabsorb salt.
Right.
And they're dying off. So these would be the first people to go with cholera.
Oh, yeah.
Your barter and your Gittleman's folks are really not going to be doing well against cholera. But, so the acute illness of salt loss can kill them.
Right.
But the chronic problem of salt retention or hypertension is going to kill them later. They don't get.
Right.
Okay. So that may be one reason. And there's just thousands of families that have Gittleman.
I think that's a good slide. Oh, no, go to the next slide.
Yeah.
This is great.
This is kind of Gittleman versus barter. They're both autosomal recessive, so they're not common. It's not like...
There is an X-linked barter. That MAGE D2 is X-linked.
All right,
that's the other thing I remember from that. Interesting,
Good.
Right?
Good, yeah. It's going to help me on the boards. And so what Gittleman's and barter have in common is they're both autosomal recessive. They both lead to hypokalemic metabolic alkalosis with salt wasting. But the difference is that in the way clinically, the first thing when we get a patient and you're wondering whether it's Gittleman or barter, this is after you've
first check and see if they're in utero.
Well, first check if they're in utero.
If they are, it's not Gittleman's.
So first check if they're vomiting.
Right.
And then check if there's a family history.
Right.
If they're not a vomiter and there's a family history, and you're not, and the age doesn't help you enough, the thing that really helps is this one.
Right.
So this would be the board's question. This is the tip-off. If they're hypocalciuric, it ain't barters.
Yeah. It really seemed when I learned a lot clinically from listening to this discussion, the Dave Ellison group. And they made some points about this. And with the barter side, it was easier because, 1 and 2 were antenatal and 3 was a little more complicated. But when it came to Gittleman diagnosis was much harder to make compared to barters. Because in the Gittlemans, they had to kind of rule out laxative abuse,
right?
Diarrhea.
Well, you got to rule out
eating
vomiting
disorders.
You got to rule out vomiting,
right?
Laxative abuse, which are much more common than Gittleman.
Right.
Vomiting, laxative abuse, diuretic abuse.
Right.
So you got to have all those screens.
Yeah.
The one I remember when I wrote the potassium chapter, I found this case which made my heart break. Actually, it was a 19-year-old woman who had a hypokalemic metabolic alkalosis, and she swore up and down that she wasn't using any substances like laxatives or diuretics and that she wasn't vomiting. But she was labeled as a bulimic and was put in a lockdown psych unit.
Ooh.
Okay, and she couldn't move because she had Gittleman.
Right.
And so this poor thing's locked in a unit where her hypokalemia that's making her not being able to move is from a genetic disorder. And if they would have taken a family history, they would have seen that, that there was some kids in the family that had it. So anyway, this is the clinically boardish. You may see more board questions. There's an old saying, you'll see more board questions about barters than you'll ever see barters. And same thing may be true for all these things. But they teach us so much about the physiology of what we do know with drugs like diuretics. So I mentioned that Gordon and Gittleman are mirror images of each other. And this is also called pseudo-hypoaldo, even though they have high blood pressure. So why would something be called pseudo-hypoaldo and have high blood pressure? Because of the hyperkalemia. So Gittleman and Gordon are mirror images, and pseudo-hypoaldosterone 2 is Gordon. Makes you wonder what pseudo-hypoaldosteronism 1, and we'll get to that. So the great thing about Gordon is that these Gittleman folks, especially chasing their magnesium, can be very difficult. What is easy about the Gordon is you just treat them with thiazides. Yeah. So the mutations in the Wnt kinases, this is the Wnt kinases, it's another Dave Ellison favorite. Mm-hmm. The Wnt kinases regulate the activity of the thiazide-sensitive cotransporter. So Gordon comes from the brake being released, and the NCCT is in overdrive. The good news is it still binds thiazides.
Right. Yeah, exactly.
So
it's like the littles of the distal convoluted tubule.
Exactly.
Yeah.
So the good news about a Gordon syndrome patient is they're thiazide sensitive still.
Right.
And so you can give them thiazides and they'll, at least that part of the Gordon will be okay. There's other parts of Gordon that won't be okay, but that part's okay.
One point about Gittleman's too, they can also be normotensive. So they don't have to be hypotensive.
Right. The blood pressure is a spectrum.
Right.
I think what's rare in Gittleman's is people that have, like me, hypertensive.
Right.
Off my meds, my blood pressure is 165 over 105.
Mm-hmm.
I don't think you're going to see that. I can tell you, I don't think I got Gittleman's. I don't think I got Gittleman's. Okay. So your PC's making all sorts of noise.
Yeah, I'm shutting off.
Yeah, mute that baby. That's just getting in our way.
No, that was this computer.
Actually. Yeah, I gotta mute those guys. So anyway, that's Gordon, and now we're going to change. Topics a little bit yes and a little bit no. We're going to talk about an inward rectifier K channel that's in the basolateral membrane in many parts of the distal nephron. And here's just a slide that shows from my friend Wang, who was at Yale. He was in Gerhard's lab when I first got there, and now Wang has gone on to many years now at Valhalla. And Wang is, I first sat with him at his patch clamp setup in Gerhard's lab in the summer of 1989. And what, from this review that Wang wrote, is the KIR 4.1 channel, which is a newer player on the block. And this is a basolateral membrane K channel that functions in the recycling of K with the sodium potassium ATPase. And what you see here is the distribution. So although ROM-K we know is in the cortical thick ascending limb, where is the type 2 barter channel we just talked about, and ROM-K of course is starting in the late distal nephron and all the way through. But ROM-K disappears And one way to tell the difference between the early and there are a couple ways to tell the difference between the early and late distal tubule. The early has the thiazide sensitive cotransporter and no ROMK and no ENaC. And the late distal, so whenever you start to see ENaC show up or NCC continue, but the DCT2 is where ROMK reappears and where ENaC appears. KIR 4.1 is basolateral potassium channel is all the way through. So what's it doing? Well, we know it's an inward rectifier K channel, like our ATP sensitive K channel. Leak. It's pump leak. So we know it's doing that. It's not ATP sensitive as far as I can tell. So it's a little different. It's not. I still don't know what the molecular identity of the ATP sensitive K channel in the proximal tubule that we worked on is. I have not. Maybe it's known, but I keep looking for it and I don't see it. Anyway, it turns out that KIR 4.1 can form a heteromer with KIR 5.1, and the functional channels may be this heteromer. And so these basolateral channels, so again, the name of his review is basolateral KI 4.1 activity in the DCT regulates K secretion by interacting with the thiazide sensitive cotransporter. So when you inhibit KIR 4.1, you inhibit sodium entry across NCC, which makes sense because when sodium enters across NCC, you need the pump. When you need the pump, you need the leak.
Right.
I hate calling it the leak, but you need K recycling.
Right.
Okay. So when you activate KIR 4.1, it's activated when you need to transport more sodium. So KIR regulates NCC expression because so here's another example of membrane crosstalk. And when you inhibit this, you not only do you regulate NCC, but again, NCC activity is tied to magnesium transport. So inhibiting KIR inhibits NCC, which is like a thiazide effect, and then impairs magnesium absorption. So these things are all tied together.
Oh, yeah.
And then interestingly enough, inhibition of KIR 4.1 stimulates ENaC activity. So his conclusions in the paper is that KIR 4.1 is the main contributor to the basalateral K conductance, all along the nephron segments, that inhibition suppresses these proteins, including NCC.
That regulate NCC.
Yeah, and that the downregulation of KIR causes hypokalemia and hypomagnesemia, like a thiazide does.
Right.
Okay, so it's sort of that. So the French group, these are great people in France. In 2000 and what is this? What does it say? You can read it. Was it 2008?
2008.
Yeah. So in 2008 they were patch clamping.
Marc Poilès.
Yeah, Poilès and Toulon.
Yeah.
And they found what you immediately recognized as a K channel. I mean, we look at the signature, the single channel recording
Inward
signature.
rectifier.
This could be our channel. So this is an inward rectifier K channel. And there's the IV plot that shows it's inward rectifying, and there's the K substitution that shows it's a K channel. This turns out to be a channel they found. Now, they didn't know what the molecular makeup was, but they did know it was an inward rectifier. They did know it was 40 picosiemens, and they did know that intracellular magnesium, like in our channel and many other inward rectifiers, magnesium is what's required to have the inward rectification. It straightens out, the IV plot straightens out if you remove magnesium.
Oh, okay.
Now, the year later, so again, here's the inward rectification. Here's the channel. Here's the family of KIR channels. And here it shows that when you it's inward current is bigger than outward current, and barium blocks it. So this is clearly going to be classic K channel, and this is what it looks like. So a year later, this paper appeared in the New England Journal. So it's a New England Journal, so it must be important. And because there was a familial syndrome of people that had this interesting constellation of brain problem, ear problem, and kidney problem. So it was, some people call it the East syndrome because epilepsy was the brain, seizures. Ataxia, sensoral neural deafness, and a tubulopathy. And the tubulopathy is Gittleman-ish. But not because of the NCC.
Right, it's because of that KIR 4.1.
That's right. Some people also call it sesame because seizures, ataxia, mental retardation, and an electrolyte imbalance, but I think I like it yeast because it's just basically simple seizures, ataxia, sensory neural deafness, and the tubulopathy.
Mm-hmm.
And this paper says that yeast, EAST,
Mm-hmm.
is caused by mutations in KCNJ10, and KCNJ10 is 4.1,
Produces
5.1.
KR.
So it causes these things and a Gittleman-like tubulopathy. The deafness that we saw in the type 4 Barters from Barton, this is a different kind of deafness, but it's in the same place. So loss of function mutations in KCNJ10 cause the yeast, and here's again current and wild type oocyte current with the wild type, and here's the mutations of these families, and you see less current, and this causes their problems. So here again, we talked about these key renal transporters, but the basolateral membrane, now what we're talking about is what's on the basolateral membrane of the DCT. This is where this other K channel is, and it's not really shown on this wing. So it's like you have to add that now, because let's say that we add that. So I just wanted to mention that because that's an interesting other Gittleman's like.
Yeah.
So that's a Gittleman's like on the other membrane.
Right.
Yeah. So now we're getting into the collecting duct, and clinically, these are the K-sparing diuretics. And I've always separated the K-sparing diuretics into two flavors: the ones that block ENaC apically, like amiloride.
Mm-hmm.
These are channel blockers, and there's a bunch of them. There's amiloride, there's benzamil, there's triamterene. We found out during the AIDS problem that people treated with high-dose Bactrim, that the trimethoprim part of Bactrim blocks ENaC. That was a paper also out of Yale that said it's an amiloride effect, and that's why high-dose Bactrim can do that, and also high-dose pentamidine. So people being treated with, in the older days of being treated with high-dose Bactrim and pentamidine could get hyperkalemia, as if they needed another problem.
Right.
And then there's the aldosterone antagonists. Again, the little syndrome folks we'll talk about, they got something wrong with the channel. They need amiloride. The licorice eaters, the black licorice eaters who have cortisol acting on the mineralocorticoid receptor, they need aldosterone antagonists. So they bind to the mineralocorticoid receptor inside the cell. And again, the aldosterone affects ENaC indirectly. So let's take a look at these. So here's the distribution of transport elements along the aldosterone-sensitive distal nephron. And what you see, it starts in the early DCT where the thiazide-sensitive cotransporter is. Then there's the late DCT where you start to get ROMK and ENaC. And then there's the connecting tubule and the collecting duct. So first of all, in green are the transporters. Of course, the sodium potassium ATP on the BLM is everywhere.
Mm-hmm.
And ROMK is everywhere. This is where ROMK becomes everywhere. ENaC starts in the late DCT, and NCC goes through the DCT, but the end of the DCT is wherever you lose the thiazide-sensitive cotransporter.
Right.
Now here are your aldosterone cortisol-ish proteins. The mineralocorticoid receptor runs the length. Now this makes sense. That's why it's called the aldosterone-sensitive distal nephron.
Right.
This is the aldosterone-sensitive distal nephron
And so
because it's, and then the 11-beta hydroxysteroid dehydrogenase, which gets inhibited by the black licorice, starts in the late DCT. So this is the players. These are the players. So here's our slide again that shows that there's two cells, the principal cell and the alpha intercalated cell. And here cortisol in the principal cell is normally degraded to cortisone, which is inert, by 11-beta hydroxysteroid dehydrogenase, but black licorice can inhibit this, and so can the genetic mutation. Okay, and here's the aldo effect, mineralocorticoid receptor in both places, as we've already mentioned, just to remind you. Okay, so here was one of the first biggies, is when Cecilia Canessa, working in the lab of Bernard Rassier in Lausanne, in Switzerland, and so here again, Bernard Rassier trained with Izzy Edelman, and he trained Cecilia. Mm-hmm. Cecilia is Izzy Edelman's research granddaughter. And, of course, Izzy loved sodium and salt, and so did Bernard. And so it was a big thing. People had looked for 20 years, amiloride-sensitive epithelial sodium channel. And the big breakthrough came when Cecilia did something very clever. She knew that ENaC binds to a amiloride. Amiloride binds to ENaC. So her first set of experiments, I'm simplifying things a lot.
Right.
But what she did was she ran her proteins over an amiloride column. And she said, what sticks to that?
Mm.
And she figured, I'll get something. So what she got out of that was she cloned what she got out of that. And then she expressed it in oocytes, and it didn't do too much.
Mm.
So she was smart, though. She said, what if this is just a subunit? So she called it the alpha subunit. It bound to amiloride, and it was also the first one. So she said, I'll call it alpha subunit. And then she made another column and said, what sticks to this? And she pulled out the beta subunit. That expressed some current in oocytes, but it wasn't robust. And then she made another column, and gamma came out of that. So she then could say the amiloride-sensitive, the long-awaited amiloride-sensitive epithelial sodium channel, ENaC, is made of 3 homologous subunits, alpha, beta, and gamma. And this was a big-time Nature paper. This essentially, if she wasn't already famous, this made her famous.
Mm-hmm.
And shortly thereafter, she came to Yale. So here is
Once when I was looking at pulse files.
This is from 20 years ago.
Love it.
So this was I made a trip during Christmas break to Gary's lab at the VA in West Haven at Yale, and Gary had some A6 cells, which are amphibian cells that are kind of collecting duct cells, and they have a native what's called XENaC, it's amphibian, Xenopus, whatever. And so you could just make a patch, and I took lithium goes through ENaC better than sodium. So I made a cell attached patch on A6 cells with a lithium chloride pipette. And so this beautiful, much different than our K channel, slow, small, lithium conducting channel. And the small channels, this is ENaC. This is the classic signature. I mean, each one of these little boxes is, I think, a second.
Mm-hmm.
So you can see 1, 2, 3 ENaCs in this patch.
Yep.
And I used lithium because I wanted to see the channels. And this was a holding potential of negative 140. And if you figure that, it's 1 picoamp divided by 140 millivolts, that's 7 picosiemens. For ENaC, for sodium, it's about a 4 picosiemen conductance. And so for lithium, it's about 6 or 7. Okay. So it's 4 to 5 for sodium and 6 to 7 for lithium.
Mm-hmm.
Now, my friend Christoph Christoph came up with me at Yale. He's from Berlin, and he came over as a visitor. It was a real pleasure to meet Christoph. We trained together in the lab at the same time. He had gone to medical school in Berlin, and he and I were learning how to patch together, and we used to celebrate. We had a way of celebrating after a good day, but we had many days where nothing worked until midnight.
We know that.
So we've had days where all the setting up was going on, and none of the data was gotten until midnight. So here is from he got interested after he left Yale. He got interested in ENaC at Yale, and then went back to Germany, and has worked on ENaC a lot. And so here's an outside-out patch this is human ENaC expressed in a Xenopus oocyte. And this is an outside-out patch. So this means that the outside membrane of the oocyte is facing the bath. And here you can see beautiful ENaC channels on a compressed time scale, because 30 seconds. And so here he adds chymotrypsin, which is a protease. And after he adds chymotrypsin, you see many more ENaC channels open, up to 7 of them open. And they're all blocked by amiloride. So what he said is that hanging on the outside, and remember the outside of the membrane is what hangs into the lumen on the collecting duct.
Right, yeah.
So ENaC's outside extracellular domain hangs into the urine.
Mm-hmm.
So what's nice about this is there was a hypothesis that came out, and I think there's pretty good data for this, which is why I put all my nephrotic syndrome patients on amiloride, is that when you we always wondered, why do patients with nephrotic syndrome get edematous? And it's not because of the hypoalbuminemia. It's because they're sodium overloaded. And
right,
why are they sodium overloaded? There's the underfilling hypothesis, the overfilling hypothesis. Mm-hmm. Well, here's an interesting hypothesis that doesn't need any of that. Maybe they're volume overloaded because their ENaC is super active. And so how would that happen? Well, when you're having proteinuria, all sorts of proteins that are never supposed to be in the urine
All of a sudden,
including
they're in
protease, are there. If they chop off some part of ENaC, because they're flowing right by it, they can activate those ENaCs. And if the ENaCs are still sensitive to amiloride, so for over 20 years, starting when I first came to Vermont in 96, all of my nephrotic syndrome patients, irrespective of whether it was from minimal change disease or diabetes, I put them on amiloride. And it helped oftentimes. And I think it helped because these people had ENaC overactivity, and amiloride still blocked the channel. So it directly comes out of this. So this is basic science patch clamp recording that immediately comes, and again, helps you at the bedside because we have this.
That's interesting. I haven't seen that.
Yeah.
Like in terms of amiloride in the setting of nephrotic syndrome.
Well, what they've also done,
to loop gyrates.
they also what groups have done is they took they made rats nephrotic, and then they took the urine from the nephrotic rat,
right,
and they put it on the patch. So they have ENaC in an outside-out patch, and ENaC is going along its merry way, and then they put the nephrotic rat urine in there, and the ENaC went crazy. And then they isolated what part of the rat urine made ENaC crazy and came up with some proteases that did it. So it never hurts. There's two people I put on amiloride right away. People on lithium. Exactly. People on lithium so they don't get their nephrogenic DI and the damage that lithium can cause. How does lithium get into the kidney? Yeah. It damages the kidney because it gets in through ENaC.
Right, yeah, exactly.
So if lithium is bad for the kidney, if it's working for their bipolar disease, but it's bad for the kidney, take it for the bipolar disease, assuming that the bipolar effect is not mediated by ENaC in the brain or whatever.
Right.
And then protect their kidney by putting some amiloride out there.
Yep.
Yeah. So I always thought it was a good idea to make, I used to joke that I was going to become a multimillionaire by making lithamide.
Yeah, that's a good one,
lithamide,
actually.
Here's your lithium, but you take it in the form of lithamide. So at the same time you're taking your lithium, you're getting amiloride.
That's a very good one.
So that was, now somebody will probably run with that.
Oh,
and make
yeah,
$1 million.
that's going to happen.
That's going to happen. But I'm talking about lithamide since the 90s. Okay, so let's go into the late distal nephron now. Again, remember this one after NCC has disappeared.
Okay.
But now we still got ROMK, but a new player comes, the amiloride sensitive epithelial sodium channel, which is inhibited by amiloride. And what I'm going to show you is that gain of function mutations cause Little syndrome, otherwise known as pseudo-hyper-aldo, and that loss of function causes pseudo-hypo-aldo type 1, which is, the type 2 was the Gordon's one. This is completely different. It's type 1, but it's completely different because it's these folks are hypotensive.
Right.
So this is the distal nephron is where there's the fine regulation of salt, potassium, and pH. And here are the players. So we already talked about Gittleman's and Gordon's. And here we're going to be talking about Little's and as a gain of function and pseudo-hypoaldo. So we've talked about Barter's and Gittleman's. Now we're here in the collecting duct where we have ENaC and ROMK. And it turns out the bottom line is this Little syndrome is caused by overactive ENaC. Remember, ENaC is the rate limiting step for sodium reabsorption along the collecting duct. And so when you have overactive ENaC, and we'll talk about why it's overactive, you're going to get hypertension. You can't turn ENaC
right.
off.
And I think, just from a big picture standpoint, just remembering that Barter's and Gittleman's are your salt losing tubulopathies. So
your salt gaining.
And Little is your salt gaining tubulopathy.
You've opened the gate, literally, for salt to come in. So, here, if you're keeping track of the genes, here's the genes we've already talked about. And now here's the gene. And then now here we are. I blocked out the Barter and the Gittleman. And here we are with Grant W. Little, who with these colleagues, again, in this journal that's hard to get, but 1963, this was the collecting duct. This is 30 years before Cecilia cloned ENaC, okay? And here's the paper. So here's the first person ever described to have Little syndrome because she went to see.
Shout out to history here. It's awesome.
So it was 1962. JFK was president, and there was a 16-year-old schoolgirl who was at school and she complained of headaches, and she went to the school nurse and she was found to have severe hypertension. Her blood pressure was a mere 180 over 110. In a 16-year-old, that's not good. Everything else was fine. So they collected her blood and her electrolytes her sodium concentration was dandy, but look, she's hypokalemic. No way a 16-year-old should have a K of 2.8. And she has a metabolic alkalosis because we know her PCO2 was greater than 40, so this is a metabolic alkalosis. Now, the younger brother, she was one of 11 kids. So younger brother's got a younger brother, 200 over 110, also hypokalemic with the metabolic alkalosis. So it looks like this kid comes from a family where there's kids, young kids, with high blood pressure and hypokalemic metabolic alkalosis, and it seems to run in the family. So first thing they do is the doctors run over to the house, and they rifle through the cabinets looking for the black
Who's
licorice.
taking what? Right.
Who's eating all the black licorice?
Right. Yeah. Right. Exactly.
Because families often eat together.
Right.
You know? So I mean, there's
some
two things.
exposure or some genetic disorder.
Now you see how good you are. So yeah, you're saying, and Little's saying, is this a product of the family's environment?
Mm-hmm.
Are they eating something as a family? So it would have been beautiful to find out that
would have been great.
It would have been beautiful to find out that 7 kids that eat black licorice.
Except as soon as they move away, the disease would go away. well,
not if they kept buying the black licorice.
Yeah.
Right. So their home environment.
Right.
Or is it their genes?
Yeah.
Okay. Is it what they're eating, or is it what's there in their cells? So here's the original patient's data, and you can just see, she got better after they started treating her, but you could see that she was wasting potassium in her urine, and back then they didn't have a Miller, but they had triamterene. So when she was on triamterene, she actually did a lot better, but she didn't take it. She wasn't adherent. Now here, I love this. This is the original Kindred. And I'll take a couple seconds to talk about this slide. This is in 1962. So here's the patient. This is the 16-year-old.
Right.
Okay, here's what we know about them since then. So it turns out that the person who brought this into the family was the maternal grandmother.
Mm-hmm.
Now, maternal grandmother had died of a stroke at a young age, like less than 50, because she had it and nobody knew she had it. So she just stroked. But she had kids, and one of them was this daughter, okay? But she had other kids, okay? And what you see is in this family, the parents of our 16-year-old, 11 kids. Here's the 11 kids, okay? 1, 2, 3, 4, 5, 6, 7 of the 11 kids
had it.
So this is autosomal dominant inheritance. This is not autosomal recessive.
Right.
And since it's boys and girls, it's not X-linked.
Right.
Okay. So now this is at the time that they discovered the family. Now here's the extended family, and then since the kids have had kids. And what you see here is, I'm going to tell you this. So in generation 1, there was only grandma.
Right.
Okay. In generation 2, they had 8 kids.
Yep.
5 of the 8 were affected.
Yep.
Generation 2.
Generation 3 was 7 of 11.
7 of 11 kids affected. And generation 4 had
10 out of
20 affected. So overall of the generations, 22 out of 39, that's 56, 50% with autosomal dominant. They're doing a little bit worse
than coin toss.
But for nearly 40 people in the family.
Right. Unbelievable.
Okay. And look how many people died of strokes. I mean, I think I put a lightning bar.
Yeah, you did.
In everybody who died of a stroke at a young age. Grandma died of a stroke.
Yeah, 5 of them.
The kids died of a stroke. This one. So
and 2 grandchildren.
Yeah. And 18 members were hypertensive before the age of 20.
Right.
Okay. So that's pretty early hypertension. And what they get in addition to the hemorrhages and the hypertension, they also have this, the urinary aldo to potassium ratio. So in Little syndrome, in the affected people, I should say, they have almost no aldo. So their aldo to potassium level, they're wasting potassium, and they got no aldo.
And their aldo shut off because they're hypertensive.
Right. So they're sodium overloaded. Right. So they could identify the kids not only from their blood pressure but also the low urine aldo to potassium ratio. Okay. So what happened to the kid? So as you just mentioned, they measured her renin and aldo because it looked like they all had hyperaldo.
Right.
So what would you call it if they looked like they had hyperaldo, but the aldo was negligible?
Pseudo.
Yeah, so it's pseudo. So the first thing was exogenous mineralocorticoids.
Right.
The doctor searched the house. There weren't any. So the plan was a low-salt diet and I think triamterene, and then when amiloride came out, amiloride. Now, the good news about, like Gordon syndrome, treating with thiazide, the good news about Little syndrome is if you catch it before they get sick and hypertensive and stroke, you got to put them, you can't just put them on an ENaC blocker. If they continue to eat a high salt diet.
Oh, yeah.
Because amiloride competes with sodium for ENaC. So you'll outcompete amiloride if you eat too much salt. But the combination, so I was lucky enough to take care of every family in the northern country, Vermont, and upstate New York, every family that had Little syndrome.
Right.
So even though Little syndrome is exceedingly rare,
Mm-hmm.
the families, you can see that the ENaC doesn't have anything to do with being able to reproduce. Look at all the kids.
Right.
So, and I was lucky to take care of large families. And even though a large family with several family members, I have one family with a dad and two daughters, and so on. And as long as they were on their low salt diet and their amiloride, they were beautiful. It melted away.
It's another beautiful example of you can have a permeability, but if you don't take in the ion,
right,
you're not going to manifest.
Yeah, in this case, you block the permeability and you lower the exposure to the ion.
But that's a good point that sodium competes with amiloride.
Yeah, well, there's a lot of lucky things about ENaC. First of all, the lucky thing, it's lucky that in the Little syndrome patients,
it's sensitive.
It's still sensitive to amiloride.
Right.
If you lost that,
forget it.
It would have been bad. So in follow-up, unfortunately, this was a kid growing up in the South. I think she was in Alabama. And, or at least they moved to Alabama because she ultimately ended up going on dialysis, the 16-year-old, probably because of bad hypertension.
Severe hypertensive.
Yeah, and she got a kidney transplant in 1989. So, I mean, it was bad news, good news, bad news, good news. Okay, so that's Little syndrome. So, again, 1963. Fast forward to this paper in 1994, which was in Cell. It comes again from the lab of Rick Lifton at Yale, because by that time, Cecilia had moved. So in this paper, you've got Joni Hansen. Joni was like Dave Simon, a fellow. She was in the same group of fellows with Dave Simon and went into Rick's lab. And Joni, when I was a first-year fellow, Joni was a fourth-year med student. And she worked with us on a nephrology elective, and she said, this is for me. And then Cecilia and Bernard Rossier had cloned ENaC.
Right.
And so this was the first paper that showed that it was the gain of function mutations in the beta subunit that caused Little syndrome. So here it was, you go back a little bit. Here's, again, another recording of wild-type ENaC. I think there's a rat ENaC, wild-type. And then here's what happened when they expressed it in oocytes. And here's what happened when they made a beta truncation so alpha and gamma were normal, but beta. And what they see is patches. So again,
goes wild.
Patch after patch of wild type would kind of show this. Patch after patch, it would show what. So what's going on? There's more MPO. We know there's more activity of the channel, but why? What's with the channel? Is it open probability? Is it the number of channels? What is it? What is it? So here's what they show. The current voltage relationship showed that what you had was the conductance of the mutant channel was not much different. Okay, so this is just showing it the channel in sodium or lithium. Okay, so again, as I told you, the sodium conductance is about 4, and the lithium conductance is about 7.
Right. Okay,
so you remember that that recording I showed you was at negative 140. That negative 140 had a current about 1 picoamp. That's about right. So here's what happened. When they injected oocytes with either 5 nanograms, 12.5 nanograms, or 25 nanograms of the RNA, here's what you see. The more RNA you inject, the more of the wild type, the more current you got, okay, up to a point. But once you got to this current, doubling the RNA didn't give you more wild type. But look what happened to the little mutation. So the beta truncation, always higher at any dose of RNA, always more current in the oocytes, and kept going up, whereas the wild type didn't keep going up. Okay, so what's happening here? So you could hypothesize.
It's trafficking more.
Well, there's several hypotheses. Either the open probability of the channel of the mutation is much longer, so an individual channel stays open longer, Could be that. Or could be that there's more of them. And if there's more of them, is it because there's just more functional channels and there's other channels sleeping? Are there less sleeping channels and more awake channels?
Yeah.
Or is it trafficking? And the answer is yes. It turns out that both. It turns out that both. That the retention signal, when a protein gets inserted into a membrane, it leaves hanging in the cell a "come get me" message.
Right.
Okay. If the "come get me" message, it's like this reminds me of when I was a kid and my friends and I would go to the movies. When the movies were over, all the parents would come and get their kids.
Right.
Not my parents. I had the little mutation. So they took me to the movie.
And they left you there.
They left me there. So little syndrome
was hypermovemia.
It was yeah. I never got back home. I sat in the movie theater. So the wild type ENACs of my friends would be picked up.
Right.
And I would be not picked up. And so
so
that
there's the signal to take it out of the membrane.
So the mutation is there, just like steady state, are there more channels getting inserted?
Yeah.
Are there less channels getting coming out, or both?
Right.
And so years of research were dedicated to figuring out that mechanism. Here was the bottom line. Bottom line was insertion is the same.
Okay.
Retention is reclamation, way different.
Okay, interesting. And that is regulated by the beta subunit.
Yeah, the beta subunit hangs in there. It's a proline
That's
rich.
the intracellular domain.
Yeah, the proline rich segments.
Cool.
That say "come get me."
Mm-hmm.
And then also other work was done to show that there were also, if you just looked at the number of channels in the membrane that were sleeping versus awake, there's more awake channels in the little mutation. So not only are they not getting taken out of the membrane, they're more awake. So here again is Joni now, the colleague of David Simon in Rick's lab in 1995, showing that not only was the beta subunit a problem, because some families had normal beta subunit. So again, just like Barter's.
Is that the gamma subunit?
Yeah, this is the gamma subunit.
Right.
So it wasn't just beta.
Right.
So because they looked at the families that they had collected, and most of the families had beta, but there was a certain number of families, many less, and I think most of them in Japan, who had normal beta. So what's the problem? Right. Well, the problem is there's two other subunits.
Right.
And alpha was okay, but gamma. So again, Joni got the gamma. And so there was a genetic heterogeneity of Little syndrome. So it turns out that yes. So I don't know if...
Now I'm dying to see the traces of what happened with the gamma subunit. Was it the same thing?
Yeah.
A recalling problem with the gamma subunit?
Yeah. So the phenotype is the same.
Right, the phenotype's the same, but in terms of
the molecular defect is different.
Yeah,
and but the molecular defect is different. But both molecular defects have the same end result.
That they're not coming out of the membrane.
Right.
Okay.
So I don't know. I looked back to see. I asked my mom, "You didn't come to get me at the movie theater. Did I have the
what defect did you have?
What defect did I have? I had to sit there, keep
You're
eating. I was eating Miller-Lite popcorn. I had my popcorn. You want butter with that popcorn? I'll have a butter popcorn. I'll have butter popcorn. I'll have a Miller-Lite popcorn.
Oh, geez.
And so, So as you say, the both of them had hyper sodium reabsorption through ENaC. The beta and gamma, same ultimate. Different mutations with the same ultimate effect of being left in the membrane too long, being left at the movie theater. Now, of course, since there could be a gain of function mutation in ENaC, couldn't there be kids born with a loss of function in ENaC? And there is. They're very unlucky kids because, and then the third fellow of that group, there was David Simon, there was Joni Hansen, and Susan Chang was the third fellow in that group. And she had her Nature Genetics paper, where they found out, once they had cloned it, they could find out who didn't have it. And so pseudo-hypoaldo type 1, meaning these are pseudo-hypoaldo means that these kids look like they don't have any aldo, but they have tons of aldo.
Right.
Okay. But they got no ENaC. So ENaC do not work out in this. And those kids will go into shock within a day or two of life.
So this is, again, this is like antenatal picked up in
this is
right at birth.
This is right at birth.
Right.
And the only way to save these kids, for a long time and maybe still, the only way to save these kids was to do a medical nephrectomy.
Wow.
because
that's the only way to get rid of that sodium losing.
I mean, your kidneys. You got two choices.
You need ENaC.
Figure out a way to give them back ENaC.
Right.
Okay, make their ENaC work.
Right.
Okay, and the Millerite blocks ENaC, but we don't have the other anti-Millerite.
Exactly.
And clearly they're not paying attention to aldosterone. They don't have ENaC. They don't have working ENaC. So these kids, I believe, I don't know what has to happen today. Maybe that we've come some, but as of the time that they published this, those kids had to have a medical nephrectomy and go on dialysis.
Wow.
And then wait until they were old enough to fit a kidney. Okay.
Incredible.
So the kids would be on PD.
Wow.
So you got to, can you imagine having an infant?
Oh.
You
got to do PD.
Kid's going to go, and look, how many different kinds of ways to die. You don't have ENaC, you die 3 ways. First of all, if you don't die, if the shock doesn't get you, the metabolic acidosis or hyperkalemia is going to get you. Because you need ENaC to secrete the K.
Right.
So these kids, what a disaster. This is metabolic disarray.
Right.
Not only what's wrong, how you doing? Well, I'm dying of shock, metabolic acidosis, and hyperkalemia.
What's amazing is they do almost like they do better with the barters, which seems like it would have much more an effect.
There's no more Nephron left.
Yes, that's it. You're right at the very end. There's nowhere to compensate.
No one's cleaning up the mess.
Yes, you need to be one tubule.
You need to be a segment back. Hanging back.
You got to hang back.
I mean, you're right. This, again, I didn't prompt you to say that, but I'm glad you did. It's exactly the point. Despite
and
what
same
you would
thing with
think,
Fanconi syndrome.
Yeah, like the loop diuretics are the ceiling diuretics. They're the very powerful ones.
Right.
So you think the loop is like, oh my God.
So important.
But there's nothing better than having more nephron left.
Yes.
And as we'll talk about when we talk about diuretic resistance, loop diuretics lead to distal tubule hypertrophy, which is one part of diuretic resistance because the distal tubule reacts to the fact it's being given a bigger load. It works out and it gets bigger. But this is the last exit. And when you don't have ENaC, so ENaC might not contribute that much to overall salt reabsorption compared to the proximal tubule. But, the reason the proximal tubule can waste some sodium because there's nephron left.
If you had to lose a segment, which segment would you lose?
I'm
not sure. That's a tough one.
A tough one.
They're all so
I like
important.
to keep all my segments.
But I think if you lost a collecting duct,
I'll tell you early on, so as not to surprise anybody, it wouldn't be this one.
Right, exactly.
Because this one, you're fine, because you're mom.
Right.
You're born.
And you're done.
And you're wasting sodium.
Right.
Yeah, you got it. So let me just show you, this is, at the IBL, where Mount Desert Island Biological Laboratory, where Homer Smith has a house. There's a little view of it in Maine, in Salisbury Cove, Maine, up as you're going toward Acadia. It's a beautiful place. Cool. And and what's there is the Homer Smith Laboratory. I think I've shown you this before. There's a Homer Smith Laboratory. And at the Homer Smith Laboratory is the kidney shed. And the kidney shed
I'm changing the name of my office.
Yeah, the kidney shed.
Kidney shed is great.
You got to have the kidney shed, New York.
I love it.
And the view from the kidney shed is this view. And this is how we learn. They got whiteboards out there. So we have med students. It's a good place to do a little summer physiology course.
That's awesome.
And so here's some. So I brought my lab in a car. All this was an empty room, and you can see here I brought patch clamp amplifier. Wow. I brought oocyte clamp amplifier. Here's the filter. Here's our dissecting microscope because we were going to do oocytes. Look at this. You remember all this?
So cool.
Remember all the PE tubing?
Yes.
Yeah. So these are all first year med students. These are med students who have finished their first year of med school and now it's their summer off. And remember this, our little syringe perfusion system? Mm-hmm. So we got the whole system going on here in our little chamber. And here's what we're looking at. What we're looking at is frog oocytes, Xenopus oocytes from these beautiful frogs. And we make these pipettes, pull these pipettes on a nice puller. And then we do what's called 2 microelectrode voltage clamp after we inject RNA. And what we had was that we had alpha, beta, gamma, ENaC. And
Did you bring a PDP-11 with you?
What was the computer that I brought? No, I was running Pulse.
Yeah, you were running Pulse.
Okay. So, no, if you put a PDP-11,
I love you
if you put a PDP-11 in the car won't move.
The car won't move.
No, that thing weighs a ton.
Oh, I love it.
So here, and you see these beautiful oocytes. If they couldn't be any more beautiful, they got the animal and vegetal pole, and so here's one of our chambers. and the chambers are some nylon mesh. Basically, it's an egg crate.
Right.
So we put nylon mesh there, and the oocytes will
Just
sit there, and they won't roll away, and we can poke them. And these go right through, and one of these is a voltage clamping electrode, and one of these is a current sensing electrode. And the voltage clamp is, when the current sensing electrode senses current, the voltage clamp is threatened. The voltage sensing electrode senses that the voltage clamp is threatened and passes current, and it passes much current to keep the voltage clamp.
Yep.
So here's what we found with these kids. We had alpha, beta, gamma, ENaC. So what we did is we recorded both in sodium and lithium ND96. So here we have voltage pulses and the currents resulting from those voltage pulses. And here's an egg injected with ENaC, conducting lithium, and killed off completely by a Millerite. They add a Millerite and there's no current left.
You got the channel.
Millerite sensitive current is all of it because there's almost no leak in this oocyte.
That's awesome.
Now, what we did was we also had beta truncation.
Neat.
So here's an egg expressing the beta truncation in sodium, and then when we add lithium bath, we get bigger currents.
But you couldn't shut it off with a Millerite.
No, you can.
Well, it's shut off, but it looks like it's still got
No,
some
that's leak.
compared. Oh, okay, that's
leak.
just leak.
That's leak. If this wasn't a leaky egg, you use a Millerite to see how much leak you got.
Right. Okay.
So this was a leakier egg.
Okay.
Okay. So and it could be that the Millerite effect wasn't as good. I can't rule it out. But anyway, what this shows is it shows much bigger currents. So on this one, in the lithium, you see we had look at this. We had like 14. So say 14. And with the same amount of RNA of mutation, we had 70. So these ENaCs went into the oocyte membrane, and the oocyte membrane knows how to take them out.
Oh yeah.
Unless the signal's missing. So here's the summary. The summary shows in lithium, and this is the summary.
That's the wild.
Different y-axes, much more current, 5 times the current. And these kids did this in a couple days. So
amazing.
I brought the lab, and somebody else brought the frogs and the RNA,
Cool.
and that's what we did this in. So these kids come on a Sunday, and we recorded this on a Tuesday.
That's amazing.
So
Really cool.
It's like doing a fellowship.
On the shores of Maine.
It's like doing a fellowship in 1 week on the shores of Maine. Pretty good.
Gotta love it.
Okay, so we've gotten through all the Nephron now, and just our reminder slide. Let's call a couple of key points. Okay. One key point is we didn't talk too much about aldosterone antagonists, but there's the old classic spironolactone, which is old and great and cheap. The problem, of course, is painful gynecomastia. That went away with eplerenone, but that eplerenone was expensive. And now we have finerenone.
Yeah.
Okay, and this is a big deal now, and I'll show you why. So again, reminding you of the aldosterone-sensitive part of the nephron. The ASDN is this yellow part, yellow section.
Yep.
Okay, bright yellow. The bright yellow is the aldosterone-sensitive. Okay, so this is where your mineralocorticoid receptor is, and also your 11-beta hydroxysteroidase, dehydrogenase 2. So to remind you again that we talked about the pharmacology and the genetics of Barter in the loop, Gittleman in the early DCT, and here in the collecting duct. And these are the genes, just to add to our gene list, alpha, beta, gamma of ENaC, and you better have it. I think it's the alpha, and again, this reminds me, it could be the alpha or the beta that is defective in the kids.
Pseudohypoaldosteronism.
In the kids born without little. Mm-hmm. Yeah. Okay. Here's the normal physiology again.
So littles only had one subunit disorder.
No.
Gamma.
No beta.
Oh, go back to that slide for 1 second.
Mostly beta.
Oh, okay. Yes. Okay. So it's loss of function. The alpha is only in the pseudo.
Yeah.
But
the little most of the littles families are beta problems.
Okay.
The Japanese littles families were gamma. And then the kids who don't have ENaC, it turns out to be an alpha or a beta problem.
Got it. Okay.
So
that's a good slide.
So again, here's the difference between, how aldosterone, this is not without too much aldo. Here's with aldo. And you see much more sodium reabsorption, much more potassium secretion, and, your other ways of wasting potassium and protons. Okay. Now, here I just wanted to show you hyperaldo and pseudo-hyperaldo. Okay. This, again, is Little syndrome. So regular hyperaldo, they're the same. They're pretty much the same. The one difference between hyperaldo and pseudo-hyperaldo is here. Here you have high LDO, and here you have negligible.
Right.
But the treatment, and this one you treat with spironolactone or a MRA, mineralocorticoid receptor antagonist, and this one you treat with an ENaC blocker because ENac's a problem. So there's Little syndrome. Little syndrome is, you got all this, lightning bolt, this thing is crazy.
Will not come out.
But there's negligible LDO.
Right.
Okay, but you don't need it because you've short-circuited. This basically...
But I think it also shows you how hard the sodium potassium ATPase works to keep a driving force for sodium reabsorption.
Yeah, it does.
But spironolactone doesn't work for littles.
And here's why.
Right.
Because there's no LDO to block. If you're going to block, why doesn't the MR receptor? You're asking the question. Why doesn't an MR receptor blocker help a patient with Little syndrome? There's nothing to block. The receptor's empty.
Right.
That's the whole point. So, unlike here, where LDO is high, and you can block it.
Right.
With the receptor blockers.
Yep.
Here, this is the problem.
Yeah.
Izzy Edelman, Bernard Rossier, Cecilia Canessa, Dave Simon, Rick Lifton, Joni Hansen, Susan Chang channel that gets into the membrane but doesn't get out. Like I got to the movies but didn't get out. And so this is Little syndrome. Yeah. You get everything and there's nothing to block. So if you're wondering whether somebody's eating licorice or someone's having Little syndrome, it's easy. If spironolactone works, they're eating licorice.
Right.
If spironolactone does nothing, but amiloride works, they got Little. There you go. Good question. And then that would be an example of a board question because they give you some.
They give you.
I like that. The licorice.
That's cool.
Because there are people born with the licorice mutation. That have defective 11 beta hydroxy steroid type 2, dehydrogenase type 2, and they're going to do better. Mineralocorticoid receptor antagonist blocking that cortisol than they are with amiloride. I think you can give them both. Mm-hmm. But your point is the better question. It's what won't work.
Right.
And what won't work in pseudo hyper LDO, what won't work for the little is an MRA.
Right.
It's like,
right.
What good is that going to do? So again, here the two PHAs are very different. They're both pseudo hypo LDO, and I don't like that. They're pseudo hypo LDO because of the hyperkalemia and metabolic acidosis, but the blood pressures are
totally different.
Well, this one's hypertension and this one's death.
Right. Yeah.
Right. So this is you got to treat these kids need to go through saline after saline after saline until you get those kidneys out. I don't know. Do you think of another way of what else could you do? Could we think of a way? Could we brainstorm a way to a kid comes out and has no ENaC? What do we do?
You're going to have to give them a clone. You're going to have to give them something to put functional ENaC in those.
So some sort of a CRISPR thing.
Yes.
Yeah. Make me some ENaC.
Make me some ENaC.
But you got to make it and put it in the right place.
That's it. Or give them a transplant.
And I don't know what other problems these kids have in life. So when these kids, people with little, so the great thing about polycystic kidney, so kidney transplants, who were they invented for? To me, they were invented for everybody, but they're also invented specifically for people who have Little syndrome. You get your transplant. You should never need a transplant with Little syndrome because you should just be on a low salt diet and amiloride. But people that have born without ENaC, they have the ENaC not in their whole body. Right. It must do other important things. We know it does in the lung and things like that. Mm-hmm. So I'd like to know whether I have to study what other pathology they may have. It might be interesting. But polycystic kidney disease is another great example of why kidney transplant is perfect because you get those polycystic kidneys out. The new kidney can't have the defect.
Right.
You can't give yourself polycystic kidney again. But back to our question of how we're helping the infant.
Right. The one
giving
who
them
has
tons
no
of saline,
functional ENaC.
You're soaking in saline.
Right. But there's still no way for the saline to go in.
But how do we prevent sodium from getting to the distal nephron? What can we do prior? We said the problem is there's no nephron left. How do we make the sodium getting to the nephron?
We got to upregulate the NCC.
Right. So can we upregulate NKCC2? So we know what turns off NKCC2 furosemide.
ooh, we need to do something with that MAGE D2 regulator of the NCC and the NCCK2.
All right. But this is how research works. This is how translational research works. It's like we got this kid, and now look at all we know, and we got this kid now who's got wasting salt like crazy because there's no ENaC. How do we bolster
proximal sodium reabsorption?
What do we do to get that sodium reabsorption? So you either got to take their. So here's one thing we could do: put them on tons of NSAIDs.
Yes, right. Well, that's how they treat Barters.
Right. So squeeze down.
Right.
On those afferents.
Yeah.
Like there's no tomorrow.
Yeah.
Put them on. I would almost put them on the medical nephrectomy of NSAIDs and ARBs.
Yeah. Right.
You're chopping
Just
the GFR.
Drop the GFR.
Yeah. So the first thing is drop the GFR.
Right.
Okay?
No, that makes sense.
Okay. Before you even get to make the tubular.
One way to do that is take the kidneys out.
Right. But
another way is medically.
Yeah. Either embolize the renal arteries.
And they're very prostaglandin dependent too. That's the other part of it. There's
probably
the tubulo-glomerular feedback with Barters gets way off.
Yeah. It was usually called that.
Right.
The hyperplasia of the of the JGA.
Mm-hmm.
Right. So anyway, that's this. And I'd much rather have Gordon, where you just need a little thiazide.
Right.
Now, this is what we talked about. It's our review slide from the Rick Lifton review that shows. By the way, we didn't talk about Geller syndrome. Dave Geller's a great guy, another person at Yale. Dave Geller. This is Geller syndrome. You happen to know what Geller syndrome is?
No.
Geller syndrome is, and I'm going to get it wrong probably. As I recall, it's a gain of function of the mineralocorticoid receptor. I'm not sure about that. I'll have to look it up. But there is a Geller syndrome. So he got
another pseudo hyperaldo.
Yeah, because it's a gain. I think it's a gain of function of the MR. Anyway, here's our Diresh. We talked about acetazolamide. We talked about all these. We talked about all these thiazides, and we talked about aldosterone inhibitors and ENaC blockers.
Yeah.
Now, let's go into some. So this is a beautiful diagram out of the Cell paper from Lifton's 2001 that basically recapitulates. What you see in blue is the low blood pressure mutations, and in red is the high blood pressure mutations.
Oh, that's nicely done. Good
Isn't that
slide.
nice?
I like this one.
I knew you would love this one because, so here's Barters all in blue in the thick ascending limb.
Right, because you got to formally, even though you learn all the players, you got to break it down into your salt-losing tubulopathies and then the ones that cause hypertension.
Right. So here, notice in the thick ascending limb, there's all blues. We got no reds. Reds would help those kids.
Right.
We got no reds. Thick ascending, DCT's got a blue and a red.
Yeah.
They're mirror images.
Yep.
Okay? Even though this is the defective transporter and this is defective Wnt kinases, whatever.
Right.
Okay? And then here's your little syndrome in your poor kids.
Mm-hmm.
Okay.
Same thing.
And this was, you can see this was made in 2001 when there was only 3 types of Barter.
That's amazing.
He's three.
Yes.
He's
too short.
Or
he's 3 short.
All right. Right. They didn't realize the Barton.
Mm-hmm.
And
they were missing the chloride channel. Oh no, they had the chloride type 3,
they had type 3 chloride channel,
not type 4.
Yeah, they had the B chloride channel, but they didn't have the Barton 4 and the calcium sensing. And I think and here's the licorice one where you have apparent mineralocorticoid excess. That's what the black licorice eaters are. And I think Geller syndrome is somewhere in here. This is glucocorticoid responsive aldosteronism. This could have been Rick Lifton's first Nature paper back in 1992 or something like that. And then one of these may be Geller syndrome in here. Anyway, there's high blood pressure, there's low blood pressure.
Yeah, that's a nice slide.
Don't you love that one?
I do.
Okay. So here's some, now I want to move from salt to water for a second. And here you see a principal cell. And here
because in our big picture, it fits in terms of aquaretics.
Flow. So here what you see, and I want to point out the principal cell. So the famous principal cell, very famous for having ENaC. Here's a slide where you have a principal cell with ENaC and ROMK not even on it.
Right.
You know this is a slide. This is Daniel Bichet. And
he's got nerve.
And no, I think he's trying to show here we're talking about water, baby.
Right.
We're talking about water.
Okay.
So here is how it normally works. What happens normally is that AVP comes in and binds to the basolateral AVP receptor when you're stimulated to antidiurese because your osmolality has gone up, your tonicity has gone up. Now notice there's aquaporin 3 and aquaporin 4 on this membrane, but they're always constitutively active. But water will not move unless aquaporin 2 is in the membrane.
Mm-hmm.
So through G proteins again, AVP binds the receptor. And by the way, there's a mutation where AVP doesn't have to bind to the mutation, to the mutated receptor, and it gets active. It's constitutively active. And it's basically these kids are born with SIADH. And through G proteins, there's signal transduction through protein kinases and whatnot, cyclic AMP and protein kinases, that lead these vesicles that are waiting. I remember my Bulgarian woman who was 40 who had these waiting for 40 years for the AVP.
Right.
And once this binds, this is the rate limiting step for water reabsorption. So AVP again, membrane crosstalk. Basolateral AVP stimulates apical water movement through this. And
causes channel insertion.
Water channel insertion. Now, vaptins, these are vaptins. So ADH binds to the receptor with a Ka of 0.78 nanomolar. Okay? Tolvaptan, which is our receptor blocker, works because it binds tighter. A lower
concentration.
A lower Ki.
Yeah.
And these are the drugs. And this is tolvaptan. That's what it looks like.
Awesome.
So that's what ADH looks like. So vaptins compete with AVP to inhibit the V2 receptor, and I call this temporary nephrogenic DI in a bottle. That's what it is.
Right.
All of a sudden, it's temporary a patient with
like temporary barters.
It's also like proximal RTA in a bottle.
Right.
What you need when you have too much water in your body is you need some. What's the best treatment for a patient with SIADH? Connect them to a patient with DI.
Right. Yeah. Right.
They'll both be fine.
Right.
Okay. So here's, and I'm not going to read this to you.
This is a beautiful summary slide.
This is a slide I made. I remember of all the slides I ever made for the med students, this may be the number one most popular slide, because this slide is that night before the test or night before the board slide that basically went over everything. I included osmotic diuretics like mannitol. Then the proximal tubule, included the indications and the side effects, the mechanism, and then also included the thiazide and the thiazide-like diuretics, all the ENaC blockers, and even phenerone and tolvaptan. So this is a slide you can look at.
It is.
It's my little cheat sheet.
But it's much better to know the cells, where it's acting, because that gives you all the complications
we could have come into
are.
So somebody's going to say, hey, these guys could have come in today and showed this slide, and I could have saved a lot of time.
Yeah.
All right. So let's go over some final notes.
Okay.
About the Lupa-Henle, the early distal nephron, and the late distal nephron. And I'm basically talking about the torsemide, furosemide wars, the chlorthalidone, hydrochlorothiazide war, and the phenerone, spironolactone war. Okay, these wars are being waged. So one comparison on loop diuretics.
Okay.
By far, the most commonly loop diuretic used is furosemide, by far. But not by me. I don't prescribe furosemide almost anymore. I prescribe torsemide. Why do I prescribe torsemide? Well, I prescribe torsemide for three basic reasons. One, torsemide has a much better bioavailability. It's not affected by food. Furosemide, look at its bioavailability is anywhere from 10 to 100%.
Right, I mean,
Thank you very much. 10 to 100. It's affected by food, whereas torsemide is much more bioavailable orally and is not affected by food. Also, they have the same onset. The half-life is longer for torsemide. It lasts, instead of the late 6, it lasts, 12.
Mm-hmm.
Also, oral to IV is 1-to-1. 40 milligrams, 20 milligrams of IV furosemide is 40 milligrams oral.
Right.
And the reason a lot of people the excuse people used to have for not prescribing torsemide was expensive. Well, I Googled it the other day. These are similar. These are kind of the prices.
Yeah. Pretty close.
Well, and when you consider the fact that this can be dosed less
What's
often.
the price of not being swollen?
Right.
Having effective diuresis.
And this is, you can dose this less often.
Mm-hmm. Right.
So I would argue that a month's supply of torsemide per month will actually be less money than furosemide per month because there's less doses you have to take. And I got this This is on Twitter, actually. I got this from Tony Brew on Twitter. Just make sure to reference the people. I mean, I don't know. He got this from these people,
Right.
but I took it directly from the Twitter feed.
Gotcha.
Okay. So
Twitter has reached the podcast.
And his point of his point of this post, one of the points of this was, torozimide's the winner.
Yeah.
I mean, the bottom line of this thread was torozimide wins.
Right. No,
And
I
believe,
see that.
and I don't prescribe. So in your daily practice, you probably still.
I still do use a lot of furosemide, but I use a lot of torsemide too. I don't really use. I maybe have one or two people who are on bumetanide because they've been on it and they're
Yeah, that's
stable,
a little bit
so
more expensive. I don't think there's any advantage of bumetanide.
Mm-hmm.
It's more expensive. I mean, I don't think bumetanide buys you anything that torsemide doesn't buy you.
Yeah.
And
I've had a number of people who failed furosemide just not doing well, and I've switched them to torsemide and they've done better.
But how about torsemide?
Right. That's what I mean. I've switched them to torsemide and they worked.
And cardiologists
They swear, yeah.
They use torsemide.
Yeah.
They love the torsemide.
Yeah.
So let's now talk for a second about thiazide and thiazide. Like I mentioned a couple times, I'm on chlorthalidone. Okay. And I mentioned that I think HCTZ got famous because it was easy to abbreviate.
Mm-hmm.
Look at the big advantages, I think. Chlorthalidone, a much longer half-life.
Yeah.
Okay. And, both of them cause salt wasting, a little bit, they inhibit the thiazide cotransporter. But the chlorthalidone also lowers blood pressure through vasodilation. So with my ARB, I'm getting some good afterload reduction along with my low blood pressure. And here is the other thing about these is the one downside of chlorthalidone is it will cause both HCZ and chlorthalidone will cause hypokalemia, and dapamide causes less of that. But it's got a better blood pressure. And chlorthalidone was just in the New England Journal a couple of weeks ago. I think I sent you that paper.
Yeah.
It's the new antihypertensive for advanced CKD. I mean, I've been using it for years like that. So I love as I said, I love me my chlorthalidone, especially because it also helps with stones.
Right.
Okay.
Yeah.
The hypocalciuria is long lasting. So I think now that you click it instead of write it.
Right. Click chlorthal.
So with loops
and torsemide.
With loops, I'm on the torsemide side.
Torsemide wins.
With early DCT, I'm on the chlorthalidone side. I haven't used much in dapamide, but when people are resistant or don't tolerate chlorthalidone, they might tolerate this because I think it's got less alpha.
And I think the other thing is to always, and you mentioned this before when we were talking about littles, is sodium restriction.
Always.
So critical.
I mean, it's some people think I'm on a thiazide.
Right.
I'm on a natriuretic, so I can eat potato chips.
And that's the point.
And that's the point. So, but I agree on the days I eat my salami and my Novalox, I take an extra. I take my blood pressure. That's what I do.
Check it.
Yeah, check it. So now, and here's I think what could be close to the last slide, which is just this, spironolactone and eplerenone are steroidal mineralocorticoid receptor antagonists. The new kid on the block everybody is excited about is the non-steroidal finerenone. And finerenone, it does a couple things. First of all, it's not steroidal. It's got less in the way of certain side effects. It seems to cause less hyperkalemia. And I think here's a big deal. It has anti-inflammatory, anti-fibrotic, which means, especially in DKD, diabetic kidney disease, the Fidelio trial, people are really excited. I think SGLT2 inhibitors and finerenone
are going to be they're the breakout.
I've heard people say, and I don't know, I've heard people say that with the advent of SGLT2 receptors and finerenone, that people who would come to transplant or ESRD are going to be pushed 15 years out.
That's amazing.
So this is a big deal for a country doctor like you.
That's for sure.
All right. Here's again, I'm not going to go over this. Here's a little play game of an idea. It's not new enough to just, I didn't have room to put finerenone on there. But finerenone would be the one we just talked about, but it's a little game of, a kidney stone person.
Match the diuretic with the clinical scenario.
Yeah, you can play with that. And then, this is the last slide there. This is the thing. So Craig, what did we talk about today?
That was as I thought it was going to be, an amazing tour of the nephron, looking at each of the nephron segments and breaking it down into the players first of all, and then the medications and the diseases that are associated. I think it was probably the most detailed review I've seen, and I looked everywhere to see what's out there.
Well, and also I think I think it's important to, I love the history and to pay tribute to it ain't called Gittleman, Barter, and Little syndrome for nothing.
That's right.
These were real people.
Right.
And they were people that did their stuff.
And I think, your introduction to Lifton's lab and like some of these people who were the key players that really unraveled a lot of these mysteries and how they were unraveled.
But I remember Lifton, when Lifton won the Homer Smith Award after this. Of course, why wouldn't he? He won the Homer Smith Award for this work, and in his Homer Smith lecture, he emphasized the thing you hear all the time: standing on the shoulders of giants. And he said, "Look, man, Grant Little, these guys had, a little clinical chemistry lab, history taking." Really going into the family history.
Oh, yeah.
And really thinking critically.
And then going to the medicine cabinet.
Don't forget it. Well, I think it was the mid-50s where aldosterone was discovered.
Right. That's amazing.
So, this is in the early days where people like Funder and Kahn, were first talking about aldosterone. So this was in the early days where people were just talking about what aldosterone did.
Right.
And they had to really use a lot of clinical acumen and prowess. So this was when doctors were, that's why we call them the giants. They were doing all this stuff without PCR.
Right.
Without, single strand conformational polymorphisms.
Genetic testing.
Exactly. all of the Barter, Gittleman, and Little work that was done in Little Lab, in Lifton Lab, as far as I can recall, was all done by SSCP, single strand conformational polymorphisms of the families they collected.
Right.
They worked out, I think Little even said, or somebody close at that time said, it's as if there's aldo around stimulating the kidney to reabsorb sodium, but there's no aldo.
Right. It's perfect.
Yeah, it's perfect.
But I think this also leaps us off to another good topic eventually, which is, and we didn't talk about it today, but it kind of fits in because we talked about if a transporter, for instance, is loss of function or gain of function. And that makes perfect sense. But what happens in the long term when we block one? So let's say someone's on a loop diuretic for a long period of time, and there's a change in the hyperplasia, like how much membrane, how much transporters are there, and you end up with diuretic resistance.
Right. And so if we're going
to
talk about diuretic resistance, let me just subliminally and silently say, DHE,
hey,
we're looking at you, man. We want you to come and join us on the Two Guys Talk About the Kidney and the Flow State. Yeah,
I love it.
And because he's kind of like the authority on that. So it'd be nice to talk to that. And I think also the other thing is to go through this, and for younger folks to form questions about, not only get curious about what we're talking about, but also take it to the next step. So when we talked about what you do with the infant who got no ENaC,
right?
Hypothesize beyond just lopping out the kidneys.
Right.
Hypothesize what methods could be used physiologically and molecularly what questions could you answer now? Could you ask now, and go to the lab and answer? Fellows tend to wait for somebody on the faculty.
They'd have to go to the Siegel lab, not the Hurwitz lab.
Yeah, fellows tend to sometimes say, okay, I'm done with my clinical year. Now what do you want me to do?
Yeah.
And there's really kind of two kinds of fellows that come through. There's the fellows that say, I finished my clinical year. I understand I have to do another year, dang it. And so what do you want me to do for a year before I can get out of here? And then they end up, maybe it works out that they go into a lab and get interested in something. That's great.
Yeah.
But it's better, I think, and more fulfilling and more productive, and probably, going to lead you to greater happiness and greater career advancement if you form your own question and you go find the faculty. So when I had to pick, a fellowship, I was in Chicago, and I had my family in Chicago, all my friends in Chicago. My life was in Chicago. It was a big city, and I loved the big city life.
Right.
And so it would have been easy for me to stay in Chicago and do my fellowship. But Jordan Cohn, as I told you in the first session, made the unilateral decision. He goes, "You're not staying here." And I said, "Why?" He goes, and I think he had two reasons. One reason he said, and one reason he didn't say. The reason he said was, "You already know everything we know here, and you got to go somewhere else to find out what they're doing." And then when I said, well, where's the somewhere else? He said, you're going to go to Peter Aronson. And I said, well, where is Peter Aronson? He goes, at Yale. And I said, why? And he said, didn't you always say you're interested in channels and electrophysiology and membrane transport?
Those are the guys.
He goes, that's the place. And so I was lucky, even though my fellowship lasted 100 years, well, 4 years, it seemed like 100. I was lucky because I went to Yale already with the idea that when I was going into the lab, I was interested to become a physician scientist and study basic mechanisms of membrane transport and specifically channels. I mean, I had that engineering background,
right?
And I loved that patch clamp,
yeah.
And I wanted to voltage clamp and patch clamp. I had studied the Hodgkin-Huxley papers, and I wanted to voltage clamp.
Yeah, that's amazing.
And so Jordan Cohn, in his wisdom, led me to be able to be one of those lucky fellows that was able to start to ask his own questions, like, I want to study channels.
Right.
What questions can I ask? And look at all the important channels we've discussed, not just in the proximal tubule channels that we studied, but all of the potassium channels that we've talked about.
But you can see how many questions there are, because every time someone comes up with something and all of a sudden there's someone who's got a phenotype of one of these disorders,
yep.
but they don't have the genotype, you got a research paper.
Right. And so I think one of the reasons, just to recapitulate the reasons we're doing this. I mean, we're doing it because we want to review, where all this stuff came from and what's our current understanding.
But it's really stimulating people to be interested in this.
Interested in this, and also asking and taking it a step further.
Yeah.
And again, of course, the real reason we're doing it is because we
love hanging out and talking about the kidney. It's two guys talking about the kidney.
Two guys talking about the kidney and the flow state. But so I think that, and we've outlined, and I think that these sessions have been good because, again, we didn't organize the order explicitly, but implicitly we kind of knew where we wanted to start and go.
Right.
And each talk is sort of built on the other ones.
It's been a perfect kind of
that's what we talked about today.
Curriculum.
And we haven't, and here's the things we still haven't talked about. Not only diuretic resistance, but we haven't talked about hypertension yet.
Yeah, no.
We haven't talked about blood pressure.
Right.
We've mentioned it a lot.
We really focused on physiology first, and that made sense to me.
Yeah, and so we still have hypertension. We haven't done the blank renal syndromes, cardiorenal and
hepatorenal.
Yeah, and now that we don't like calling it kidney rather than renal, we got to name it, heart kidney syndrome.
Yes.
And liver kidney. To me, it always makes sense, heart kidney syndrome and liver kidney syndrome, rather than hepato.
Right.
I got nothing against that stuff.
Yeah.
I grew up with it, but if you want people to understand what you're talking about, hepato is not as nice as liver, and cardio is not as nice as heart, and renal is not as friendly as kidney.
Right.
So that's why we're the two kidney guys.
Hey man, I love it. Alan, thank you so much. That was just an awesome, again, amazing review, and you have such a deep insight, and your knowledge of a lot of these people and the labs and how they work together, that adds so much to it. So thanks for putting that out there to everybody. We really appreciate it.
Happy New Year. Good way to start off the new year.
You got it.